So let's begin today's event entitled Nutrition and the Continuum of Care, Preconception to the Postnatal Period. My name is Sandeep Patala, and I'm the Senior Program Associate for the Maternal Health Initiative here at the Woodrow Wilson Center. Today's event is brought to you as part of our Advancing Dialogue on Maternal Health series. Through that series, we look at many critical and neglected maternal health topics, and we are generously supported by the Maternal Health Task Force, as well as UNFPA, or the United Nations Population Fund, for that work. As many of you know, the Wilson Center is a formal memorial to our 28th president, and we bring the worlds of policy, practice, and academia together. But I wonder if you know that we were recently voted the #1 think tank to watch in the U.S. and among the top 10 in the world by a recent survey. So you are cutting edge by joining us here today. Speaking of things to watch, I want to point out that today's event is being live webcasted. So what that means for those in the room is that when we do get to the discussion, I'd ask that you wait for a mic, and my colleagues will be around with them. I'd also ask that you introduce yourself and your affiliation so that those tuning in can know exactly who is in the room. For those tuning in, I want to point out that we're using the Twitter handle hashtag #MHDialogue. If you have questions, we'll be monitoring over Twitter, and we can then convey them to our speakers here. For those in the room, if you do need a Wi-Fi passcode, it's written on the side of the wall. It's capital WC, lowercase JUN006. Excuse me, sorry about that. And I want to direct your attention now to our speakers. I will introduce them since we have a good representation here of those worlds that I was talking about that we bring together. I'll introduce them individually before they speak, but more detailed bios are available outside the door. But I wanted to just take one moment. As I was prepping for today's event, I found some neat statistics that I wanted to share with you. To help frame what we'll be talking about today. I learned that maternal short stature and iron deficiency anemia, which can increase the risk of death of mother at delivery by at least 18, let me start that over again. Maternal short stature and iron deficiency anemia, which can increase the risk of death of mother at delivery, contributes to at least 18% of maternal deaths in low and middle income countries, and anemia rates have not improved appreciably over the past 2 decades. So we have a lot of work. There's a reason that we're here talking today. Maternal undernutrition also increases the probability of low birth weight, which in turn increases the probability of neonatal deaths due to infections and asphyxia. Globally, almost 50% of pregnant women, that's 56 million, are anemic. And because adolescent girls and women of reproductive age lose iron through monthly menstruation, and because their diets are often lacking in iron, they are particularly vulnerable to iron deficiency. And the prevalence of night blindness, which is an occurrence or consequence of vitamin A deficiency, is more common in the 3rd trimester of pregnancy. And populations with a prevalence of greater than 5% are considered to be at significant public health, or considered a significant public health problem. It is currently estimated that 9.8, so almost 10 million pregnant women are affected by night blindness worldwide. And lastly, I was reading about links between calcium and risks of gestational hypertension, preeclampsia, and preterm birth. So hence the need for the robust panel that we have today. And we're going to start by hearing from Justine Cavelle, who is the Senior Program Officer for Nutrition at USAID's MCHIP, or Maternal and Child Health Integrated Program at PATH. So thank you.
Thank you, Sandeep. Good afternoon, everyone. Thank you all for joining today. I'm going to be speaking about addressing perceptions and cultural beliefs of maternal dietary practices, weight gain during pregnancy, and postpartum family planning in Egypt. Is it better if I... Okay. I'd like to acknowledge our collaborators and our team, both in Egypt and the US, that contributed to this effort. The American University in Cairo Social Research Center, the National Nutrition Institute, our SMART project, which is MCHIP's project in Egypt, the University of North Carolina, and the George Washington University Milken Institute School of Public Health, and the individuals named here in this slide. In this map, Egypt is among 34 countries with the highest burden of malnutrition, according to the recent Lancet Nutrition series. Maternal obesity is rising, and 79% of Egyptian women are considered to be overweight and obese, according to their body mass index. Egypt is also facing what is known as the double burden of malnutrition: stagnant and rising levels of stunting, or chronic malnutrition, where children are too short for their age, in conjunction with rising overweight in children younger than 5 years of age. Maternal diet plays a role in the prevention of chronic malnutrition or stunting in children. If we look at this conceptual framework, we can see that beliefs and norms from the community and societal perspective feed into maternal dietary practices at the household level. Inadequate diet can contribute to restricted growth in the womb or in utero. About 1/5 of children can become stunted beginning in the womb. So adequate growth and development and attainment of height, potential, and adequate weight can be achieved through adequate maternal diet. And in the short term, you can see decreased mortality, morbidity, decreased health expenditures, and improved cognitive development. And in the long term, we can hope that by preventing stunting through improved maternal diet and optimal feeding practices for infants and young children, we can decrease the risk of obesity and associated illnesses, increase school performance, learning capacity, and also increase work productivity and gross domestic product. So preventing stunting and also encouraging optimal maternal diet has a role in improving the growth and development of children and also the development and productivity of nations. There has been an alarming increase in overweight and obesity and non-communicable diseases, or what is known as NCDs, in the Middle East and also in Egypt. Several factors have been documented that may contribute to this rise. There's been a tendency on the public health system to focus on treatment rather than prevention. There has also been a shift from traditional diets to unhealthy diets characterized by high fat, salt, and sugar intake, and that also means higher intake of processed foods. Societies have shifted to be less physically active. And in Egypt, subsidies of energy-dense, unfortified wheat flour, sugar, and oil are also thought to play a role in this rising phenomenon. However, it has largely been unexplained as to what's happening in Egypt. A deeper look at cultural factors and beliefs can aid in understanding why mothers choose certain foods and what are the motivations behind these choices. We conducted operations research in Egypt to examine perceptions and cultural beliefs on what are the norms around maternal diet during pregnancy and what foods are mothers choosing following birth among breastfeeding and non-breastfeeding women, what they believe about weight gain during pregnancy, birth spacing and family planning following the birth of their child in the first 2 years. And it was within the context of a larger operations research study, which we're looking at factors associated with stunting and beliefs and perceptions and around infant and young child feeding practices in Egypt. We sampled from our MCHIP SMART project in Lower and Upper Egypt 120 pregnant, lactating and non-lactating mothers, where we conducted semi-structured, in-depth interviews to understand these perceptions and beliefs and cultural norms around foods that were conducted in Arabic, transcribed, and translated into English, where dominant themes were identified and a coding scheme was developed by our research team, and qualitative analysis was carried out using appropriate software. There were 2 sites for this operations research in Egypt, one being Kaliyabaya, Lower Egypt, which is in the Nile Delta, north of Cairo, a semi-urban area characterized by they grow maize and fruits, cotton, as well as the largest producer of chicken eggs in Egypt. We also conducted the study in Upper Egypt in Sohag, which is an agricultural area known for producing clover for animal husbandry, as well as sugarcane. I'll now present the key findings from these in-depth interviews regarding perceptions of foods to eat and around diet and weight gain during pregnancy among pregnant and postpartum women. Egyptian mothers had knowledge of healthy foods to eat during pregnancy. Mothers perceived good and beneficial foods such as chicken, eggs, these animal source foods, lentils and beans, and fruits were known to strengthen a child's body. Yet often women restrict intake due to personal preferences. I don't like lentils or beans, or affordability and limited income. I don't have much money, so I am not able to purchase chicken or meat, and I rarely consume these items. Mothers had perceptions about what is considered taboo or bad foods for pregnancy. For example, junk food causes cancer in the blood, miscarriage. Other mothers said salty foods, like salty cheese, cause allergy or malformation to the child. Acidic foods, such as vegetables simmered in tomatoes, which is a local family food, causes colic and causes hemorrhoids, so I avoid those foods. On the other hand, mothers were correct in saying that caffeine can be stimulating and reduce the absorption of iron. So mothers largely had misinformation regarding these taboo foods. Junk food is sometimes a taboo food. Some foods the pregnant woman should not eat are all the dark sodas. Light sodas, light colors, they're okay, says a pregnant woman 6 months pregnant from Lower Egypt. Another pregnant woman says, foods which contain preservatives are bad. For example, potato chips, cheese, and luncheon meat. These have no benefit for the pregnant woman. My mother told me that. I have to drink soda daily. I also drink juices that I buy from the store 2 to 3 times a week. So caffeinated beverages, the dark sodas, foods perceived to have preservatives were frowned upon by pregnant women. But non-caffeinated sodas and store-bought juices were perceived to be acceptable, and pregnant women consumed them in large quantities. So junk food is not always restricted. A pregnant woman from Lower Egypt says, things I like to eat are creamy, spicy, and salty food. The salty food causes deformation of the child and gives the pregnant woman allergies. I think sodas and lemon are not good for pregnant women, but I like these things and I eat them. I have beans and tamea, which is patties made of fava beans, for breakfast with pickles and salty cheese. So the way mothers view foods, whether they're favored and liked or whether they're appropriate, these are important drivers of women's food choices. Another pregnant woman from Lower Egypt says, a pregnant woman gains extra weight because extra weight is being formed around her, the baby. She will gain weight because the baby is gaining weight. It has nothing to do with her health or her nutrition. So there is no reason to keep the pregnant woman from gaining weight. This quote illustrates that mothers do believe that weight gain is essential during pregnancy, but they believe it's only because they have an additional person in their body. And they often would not make the connection between nutrition and what they eat and the health of the child or the growth of the child. So women lack this knowledge of optimal weight gain during pregnancy, and this is largely because they are not counseled by health providers on what they should gain during pregnancy. On the other hand, breastfeeding mothers, they eat more during lactation, and they try to eat nutritious foods to increase quality and quantity of breast milk. They restrict what they eat to the following, including milk, radishes, leafy greens, lentils and beans, and chicken, eggs, and red meat. On the other hand, they also think that halwa, a traditional sweet dish made of sesame paste, butter, and sugar, is also going to be good for breastfeeding. Mothers' restricted consumption of foods considered to be taboo during this life stage, during breastfeeding, thought to decrease breast milk production and possibly harm the mother and the child. What is bad for lactating women are potato chips, soda, and fast food. Sodas affect the bones. Chips is not nutritive, and fast food is greasy. All of this is transmitted through the milk to the child and harms the child in the same way. Lactating mothers also restricted certain vegetables like cauliflower and Amenorrhea, which is a green leafy local vegetable, and also fruits like mango, because they perceived that it would cause diarrhea for children. So food restriction can also limit the variety of foods that children or mothers are given or eating. When a woman has stopped breastfeeding, though, she can eat anything she wants. One lactating mother from Lower Egypt says, "I like potato chips very much, but my husband prevented me from eating it during my pregnancy to protect me and the baby from the preservatives that can affect our health. But now after giving birth, I feel free to eat anything, even chips." Another woman from Upper Egypt says, she, the non-lactating woman, must eat foods rich with iron and calcium, like vegetables, to provide her with good nutrition and to be able to become pregnant again in good health. She can eat any kinds of foods, and there is no food that is bad for her. So mothers felt there were no dietary restrictions as long as they were not breastfeeding. So in contrast to pregnancy and lactation, non-lactating mothers stated, "Nobody can tell me what to eat," and they can indulge in any desired food, even junk foods. In Egypt, mothers tended to stop breastfeeding even though breastfeeding is recommended for 2 years and is supported by the Quran, the Muslim holy book. Once the child becomes 1 year of age, mothers said children are grown up and old enough to eat. And early weaning is also supported and encouraged by grandmothers and other family members, for example, sisters-in-laws. Mothers also became pregnant at this time, so therefore stopped breastfeeding. When we asked mothers also, when they are breastfeeding, is it possible for them to use breastfeeding for family planning? And do they know anything about what is known as the lactational amenorrhea method? Their views on becoming pregnant while breastfeeding varied. Lamb and breastfeeding, that is the same thing, one mother said. Natural lactation is when a woman gets her period, and if she doesn't use a family planning method, she conceives. Breastfeeding without a menstrual period or clean lactation, this way a mother doesn't get pregnant. And then another mother mentions God's will. "I have been lactating and not gotten pregnant. My aunt and mother got pregnant while lactating. This is from God." So these quotes illustrate that mothers may understand some component of using breastfeeding for family planning or the lactational amenorrhea method, but they don't understand the 3 criteria for it to be effective, meaning exclusive breastfeeding for the first 6 months, and that the mother has no menstrual period. Mothers did, however, stress the importance of birth spacing for 2 years and understood the importance of family planning. Counseling mothers on incorporating a wide variety of foods for a healthy pregnancy, optimal fetal growth, and adequate weight gain during pregnancy is essential. Maternal diet and weight gain during pregnancy are the cornerstone of ensuring good pregnancy outcomes and optimal growth and development of children. Many women in Egypt are overweight. So this concept of eating for two may not be the right message we want to give women. Carrying too much weight during pregnancy may have adverse effects on the fetus, setting the stage for increased risk for obesity over the child's lifetime. And that mothers who are overweight and obese, they should know that they must gain less weight during the second and third trimester. For example, obese women should only gain 5 to 9 kilograms during this period of time. Counseling on maternal diet also serves as an opportunity to address feeding these same nutritious and diverse foods to infants and young children who also consume junk foods. In our operations research, we found very high consumption of junk foods among toddlers, meaning children under the age of 2, starting as early as 3 months of age and peaking from 1 to 2 years of age. Junk food should be limited, not only for mothers and children, but for all family members. This is a household issue in Egypt. Community-level strategies should prioritize educational messages and meet mothers and families where they're at, looking at and responding to cultural beliefs and perceptions, and using that information to work with communities on reducing junk food and eventually eliminating these intake of nutrient-poor foods. Exclusive breastfeeding in Egypt is low, and in our study, only 1 out of every 4 women were exclusively breastfeeding, and we need to be able to support exclusive breastfeeding and also continued breastfeeding. But it can only be reinforced by teaching mothers about exclusive breastfeeding, but also about LAM, an effective family planning method for the initial 6 months postpartum, which benefits mothers in protecting them against pregnancy and has the dual benefit of also benefiting the child in ensuring their health and survival. Thank you.
Great. So does anybody else see the irony of us having chips today for our nutrition discussion? We can certainly have a session exclusively focused on the cost of fruit versus the cost of junk food, though. I certainly want to express my appreciation for your comments. I think that your discussions around breastfeeding in particular really are going to help begin the process of the continuum of care that we'll hear from our other speakers about. I also appreciated that, of course, we expect when we talk about nutrition to think about in the context of the countries that we're focused on, to think about folks not having access to food, but not as a not small woman, in particular, I appreciated hearing the other spectrum, that malnourishment isn't just about lack of access to food, it's type of food as well. So we generally do take questions at the end of our sessions, but again, since we have such a robust panel, I do want to take a moment if anybody has any clarifying questions for Justine before we move on to Ranu. Please let us know. Okay, so do you want clarifying question? Yeah. Just if we could wait for the mic, though, so that those folks.
There's also, yeah.
Oh, okay, great. Yes, I might need a little help with that side of the room.
My name is Denise Leonetti, and I'm with PATH. And Justine, I just wanted to ask if the cause of so much junk food being eaten is driven by media. I mean, what's behind that?
Mm-hmm. Do you mean in mothers or in children?
Mothers.
The study was primarily focused on infant and young child feeding practices for children to prevent stunting, but for mothers, they didn't really talk much about the media, though I think marketing is definitely of concern because it's not regulated. They don't have any food labels. Women in general, whether it's concerning their diet or their children's diet, are just simply not aware that these foods do have detrimental effects and can contribute to overweight and can affect children's risk of becoming overweight and obese. and that they're actually bad for them and they have low nutrients and high fat. So there's a lack of awareness in general about the content of these foods and the health effects of these foods. And when you think about the US, we've only recently gotten calories on the menus. So Egypt has a long way to go to be able to educate the population about what that means. And there's also access issues. Every kiosk has these chips and other junk foods. So.
And I think there was another clarifying question in the back.
Hi, Allison Roberts with the CSIS Global Health Policy Center. I was wondering if you could kind of talk about how you chose the sites since they were both in agricultural areas. Do you have any idea what responses would have looked like in more food insecure areas, or how food secure were these areas?
Well, actually, the study sites were chosen. This is a USAID commissioned study. And in Lower Egypt, there was a doubling in stunting between the two large demographic health surveys, 2005 and 2008. Now, that rise in stunting coincided with the avian influenza outbreak. So that was Lower Egypt. And Upper Egypt, there was a slight decrease in stunting. Those two sites were primarily chosen because, one, the MCHIP is working in those areas. Two, we wanted to investigate what was happening with the rise in stunting that area compared to an area where there was a little change in stunting. So Kaliabaya is actually a semi-urban area. Even though it looks somewhat agricultural, people actually live in high-rise buildings. And it's fairly densely populated. Villages in Egypt are comprised of about 20,000 people. These are not small areas. And so Hag is more agricultural in the sense that houses are more far apart. There's probably going to be less of these kiosks that have junk foods. But Upper Egypt has also had more of an NGO presence and more development going on there. So this also plays a role in feeding practices as well.
Great. So just if there are any clarifying questions, because we do want to move on. So if anything wasn't clear in the presentation, otherwise we'll open it up for larger questions. Any more? Okay, so why don't we move on to Ranu Dhillon, who is the Senior Health Advisor for Earth Institute at Columbia University. He's also faculty for the Division of Global Health Equity at Brigham and Women's Hospital at Harvard Medical School. And amongst his many credentials is that we grew up together going to Temple. So Facebook network, you'll never know what comes from that. And Ranu's going to take us from hearing about perceptions and cultural beliefs and the effect on dietary maternal practice to responses to such perceptions and beliefs.
Great. Thank you, Sandeep. So it's a real honor and privilege to be with you all today. I will say as a disclaimer up front, I'm not a nutritionist, but I work with a lot of really great nutritionists, and I hope I do them justice in terms of my understanding of at least the technical aspects of the issues. So my background and the work that I do is primarily on how do we actually build and execute health systems? How do we actually make delivery work on the ground? So a lot of my experience is both sitting in villages, building and managing local health systems, as well as increasingly now trying to work with governments on how do we take all the great things we can demonstrate in niche projects and get it to work across scale. And from doing that work, I think, especially from the ground level, the issues of nutrition and health that sometimes get separated out when we talk at a policy level or a little bit further from the ground, when you're closer to the village, you see that these things are really intertwined, both in terms of the patients and their experience, as well as the mechanisms we have at the ground level to try to address them. So I'm going to talk a little bit about some experiences and opportunities within that. But first, just to add to some of the framing of the issues that Sandeep had done earlier, to me, I think right now in health and health systems discussions, the notion of universal health coverage is sort of the organizing platform. And I think it's almost been a little bit shocking to me that nutrition has not been really anchored to that discussion of universal health coverage. Certainly in universal health coverage, we tend to focus a lot on financing, and we haven't really addressed delivery, which I would argue we should be actually talking about universal healthcare delivery, not just coverage, certainly coverage as a starting point. but I think nutrition has to be front and center to that. I'll talk a little bit about personal experiences of why that's sort of inseparable in my mind, but also just looking at the numbers. So 85% of the world's population lives in low and middle income countries, and a quarter of kids in those countries are undernourished, right? So that's 165 million kids. So just to put that in perspective, if we were all the kids in low and middle income countries in this room, this whole side right here would be undernourished. So not only a massive proportion. And 165 million, that's half the US population. Only 7 countries actually have a larger population. So we're talking about a substantial issue. And then secondly, for this point of universal health coverage and really making nutrition part of that discussion, what's striking to me is that a half of child deaths, so universal health coverage is oftentimes premised on how do we close the gap on MDG 4 and 5, so maternal and child health. Half of child deaths are driven by undernourishment. So it's sort of inseparable to me that we can actually try to frame policies and approaches to aggressively close the gap on child mortality without actually making nutrition part of that discussion. And the point being that we actually have ways that we can address undernourishment, and I think a lot of those ways can actually be either done or mediated by health systems. So certainly there's a wider range of nutrition interventions than the 10 that the Lancet series underscores, and I think particularly people from the nutrition community might be upset if we only talk about those 10. But just to use them as an example, certainly 7 of them, leaving out breastfeeding, leaving out micronutrient supplementation, can either be delivered through health systems or mediated through health systems. And mediating can be a wide range of being a fallback if other mechanisms are not working. Or secondly, I would actually argue health systems should actually be engaging with each household to really understand who has received which of the interventions, nutrition and health, and who hasn't. And that's something we don't do well, and it pertains to antenatal care coverage as well as immunization. And I think health systems need to become more oriented towards doing that, and I'll come back a bit to that later. So the question then becomes to me is, from sitting on the ground, why is coverage so low? For a lot of these 10 interventions, coverage is somewhere between 30 and 70%, right? Frequently around the 50% mark. So I'm simplifying some of the numbers to make the point that if we actually were able to get higher coverage, we should not only be able to make a ding in reducing child mortality, we should be able to make a dent, right? And it's sort of this, what's striking to me as someone who works on delivery is that we're not waiting for some new medicines. I'm not waiting for some new invention. I'm not waiting for some new technology. It's really a matter of how are we going to deploy this so that everyone who needs it gets it. And then why does it not happen? And so almost kind of walking backwards from that. So I'm going to talk a bit about what I think are some of the challenges and what I think are some of the opportunities. But before diving into that, I think it's helpful to try to understand some of these challenges from the lens of patients themselves. And not too long ago, I was in a state that I'll leave nameless, so as not to accuse any of the leadership of the state of bad governance, but a state that I'll leave nameless in India, driving distance from where my dad actually was born. And my dad actually grew up malnourished, and now my nephews and nieces in the same village are having problems of malnutrition on the other side, being overweight. And so it's amazing how much things change. But this is an area where malnutrition, undernourished nutrition is still very severe. And I was working with the team, which did have some really great nutritionists. So I was just the systems person, but we had some great nutrition experts with us, going to assess a district hospital and some of the different programs they had running through it, including a malnutrition ward, to understand how well it was working, what are the gaps, what needed to be done, both to figure out what needed to be done at that place as well as try to inform some of potential policy changes. And when we were in the ward, we came across a baby, a little girl who was 7 months old, looked more like 3 months old. And she was basically almost comatose. We had really difficult time arousing her. So the story of how she ended up there was that her mother was likely undernourished in pregnancy. She was frankly anemic when we met her. And sort of almost like walking from her pregnancy forward, right? It sounds like she went to all her antenatal care visits, though she didn't have proper documentation of that. Unclear whether she got IFA supplementation. She did say that she was given some tablets she was supposed to take, but again, not completely clear, but certainly at least for some portion of her pregnancy, that was dispensed. But when she ran out of the tablets, there was no clear mechanism for her to get the sort of next installment of it. And then I'm imagining she was anemic during pregnancy. And in a lot of states in India, the poorest states in India, anemia among pregnant women is as prevalent as 70+%. So she certainly probably would have fit that. Her background was she was a low caste woman. She actually farmed a small plot of land. Her husband also is low caste and did sort of odd jobs and odd hustles just to try to get some income. And so it sounds like during pregnancy, she got some smattering of maybe some interface with the health system and maybe some fragmented level of actually the interventions that she should have gotten. When her daughter, Rena, was born, she wasn't sure whether her daughter was low birth weight. Apparently, she was not told one way or the other, so we don't actually know that. Later, in some assessments we had done in this area, we actually saw that the scales that the nurses were using to measure the newborns were very crude, and oftentimes they would just actually round up to the nearest kilogram. So, it's sort of like a blunt way of trying to measure something that, plus or minus some grams matters a lot, right? And so clearly, one of the challenges to that would be, even if she had a documented birth weight, what would we know by that? So it sounds like, nonetheless, she was a sort of normal, happy baby, probably, I'm guessing, at least on the lower end of the growth curve, again, speculating. And what then happened was a month before we met her in this ward, her father died. Unclear circumstances. He may have either gotten killed or it was some sort of an accident. And in that culture, in that society, there's this notion where if a woman is without a husband, her social value, which is already very low, becomes almost, that's sort of, you're defined by your husband. So the family sort of unraveled after that happened. And certainly they had less money coming in. So her mother, who was already malnourished, was eating less, probably not producing as much breast milk. I also got the sense that she was suffering from some kind of depression and may not have actually been feeding Rena as regularly as she should. And so her daughter actually got worse, probably was already malnourished and sort of had acute on chronic malnutrition, which I think is probably a fairly common pattern, and certainly in this kind of a setup where people are already on the brink, and anything that pushes them over then exacerbates whatever issues are already there. And then a couple weeks before we met her, it sounds like she started developing diarrhea. And so this is where, if the health system didn't have a reason to kick in when she was already not doing great and was chronically not well, now she's acutely not well. So what happened with the health system? So as many of you know, in India, there's a program to have something of a nutritional supplementation feeding center in every village. So she didn't go there. And, we were asking, well, why didn't you go there? And to her, it was not even an option. She says, I'm a low caste woman. The staff at the clinic, the feeding center, are high caste. They're not going to accept me to come. In fact, it was so imprinted in her mind, and maybe the person there would not be as discriminatory as she thinks, but it was so imprinted in her mind that it didn't come up as an option, and she's like, no, that's not a good option. Let me go to option number 2. It was not even an option for her. She didn't even think of that as a possibility. So second thing, her daughter kept having diarrhea. So she wanted to take her to a place where she could get seen. So in India, as in many countries, local level healthcare delivery, even when it's there nominally, functionally is very limited. So what can happen at a subcenter, which is your local clinic in India, which is similar to a health post in other settings, was very limited. And staff absenteeism was a big challenge. So she again didn't go to the subcenter. She had to walk several kilometers to get to a primary health center, which is for many people their first line of care. And in most countries, primary health centers cover catchments of about 20,000 people. It certainly depends on geography, but that's sort of not an uncommon sort of system design. So she got to the primary health center, and they never screened her for being malnourished. It never happened. They gave her some kind of, what I'm presuming was an antibiotic that, in her case, medically didn't even help her. So her diarrhea continued, but was not screened when she's clearly already malnourished and getting worse rapidly. And then Rena's mother and her went back home. So when she's back at home, she's just getting worse. Diarrhea is continuing. She's actually getting weaker. Her mother describes it as, she's so weak that she's sleeping for long portions of the day, having trouble really kind of keeping her head up when she is awake. So, her mother did what I think any mother would do, and she sold whatever few possessions she had to be able to get a ride into the nearest town where there was the district hospital. So when she got to the district hospital, they immediately recognized that she was malnourished, and they put her in the malnutrition ward. So first time she's getting the right diagnosis many kilometers away from her home. So she's in the malnutrition ward, but then she actually was not getting better. And then we're trying to understand why did that happen? So one thing is the ward was staffed by a nurse who, even though she was in charge of the ward and even though she worked really hard to try to take care of the kids there, she herself never had full and proper training on how to actually manage malnutrition. She doesn't know what the feeding cycle should be. She didn't have a sense of that. The pediatrician who was supposed to be supervising the ward, and this is why I left the state nameless, was sort of nowhere to be found. Although I think in many countries, and I'd say in many places I've been in India, that can apply to many different states. So the pediatrician, the word is that he was at his own private practice and was not around. So even the day when we were there, about an hour after we were there, we had called him a number of times, and he finally showed up. And at that point, she was actually even less arousable, kind of taking shallower breaths. So we were actually, the clinician side of me was concerned that she's basically imminently gonna pass away that day unless more aggressive care is given. And so we tried to actually talk about how do we get her to higher level care. This is someone who's in the public health system. There are referral pathways. But basically the pediatrician said there's no way we can refer her, that we can transfer her because of transport and a combination of other reasons. And his response was basically, he's like, yeah, these people, this is how they die, right? So long story short, after a lot of negotiations, some of which was somewhat hostile, we ended up taking her directly to, we took her directly to the nearest city, which is a fairly large-sized city in India. On the way, we had to bag her, basically breathe for her because she was so weak and really not taking enough air in herself. Our plan was to go to the first private hospital that we knew would have a ventilator. The public hospital certainly has ventilators, but we know that it's very overcrowded. So we were worried that if she needs to get intubated very quickly, we couldn't afford that delay. So we went to the first private hospital. We got out, we went into the intake area. A pediatrician who was on staff there, who basically looked just like one of my uncles, in fact. We looked at her and was like, yes, she's not doing well. And we're like, yes, she's not doing well. And so I started like rambling off what we need to do. We need to get this ready. If you have a ventilator, et cetera, et cetera. And he actually stopped me mid-sentence. He's like, oh, but I can't accept her here. And I was a little bit shocked. And his excuse or his statement, which he said very matter-of-factly, not even as a sort of an excuse, was, this is a girl child from a low-caste family with no menfolk. And what he meant by menfolk was that she didn't have a father. So no men, and particularly in order to accept her, he said he needed a man's signature. And I was like, am I not a man? Can I sign? But he said it had to be a relative. And of course, she didn't have any relative, at least for kilometers. So literally, he was like basically forcing us out of his hospital while we're still bagging her, right? And while we're waiting, she actually has some more diarrhea. And they actually would not give us napkins to help clean her. One of my colleagues had to go to the hospital pharmacy and buy napkins so that we could clean her. Very undignifying. So long story short, we ended up getting to another hospital, another private hospital, where we did get her admitted. And she had sepsis and a lot of acute medical issues that did get better. And then it actually got to a point where I'll leave out there's a lot of challenges with her being low caste at this hospital, et cetera. But the thing that really struck me is that, so clearly when her acute medical needs got better, she needed to improve her nutritional status. Otherwise, that would only be a matter of time before she gets ill again. And because it's a for-profit private hospital, almost by definition, they never see malnutrition. Or certainly they see some forms of malnutrition, but not that such severe undernutrition. So they actually had no idea how to manage it. They're like, we literally don't know how to manage this. So my colleague, who's a nutritionist, who was with me to actually evaluate this hospital, was actually preparing her feeds herself while we were at that hospital. Ultimately, when she got medically better enough, we made a shift to go to the state government hospital, which did have a very large malnutrition center and ward that was appropriately staffed and too used to managing these cases. So when we actually got there for intake, there was a line of maybe like 80 mothers and grandmothers with sick children. I'm speculating that a lot of them were undernourished. I think my speculation probably be right. Some of them, in fact, some of these kids are actually already intubated, and the mother would be like squeezing the bag while waiting in line to be seen. And the pediatricians, who I will say, are very tremendously overworked, interacted with each person with a lot of compassion. And what they would have the mothers do is hold up the children so they can try to triage and see who needs to be seen faster. And several times there were some kids who were actually already dead, and they had to go up and tell and say, like, your child's actually passed away. So long story short, we eventually get her into the malnutrition center there, and they were phenomenal. The staff there were very strong. They knew what they were doing. She started getting better. But the thing that actually was the most upsetting is that she was there among many kids with the same exact story, right? So I'm telling you this is all anecdote. I don't know percentage of the number of kids who end up here who had the same kind of trajectory. But I got the sense that this is a common pattern. And actually, what was actually more disturbing was that I'm sure these kids are actually the exception, right? These are the ones who actually made it this far. And particularly in that state, there's some places that are very remote from any kind of large city, like the one where we were, where you would imagine there's some capacity to manage these cases. So to me, almost looking at that whole trajectory, it gives me a lens into why, actually the thought to me is not why is coverage so low. I'm like, why is it not lower? Of certainly the nutrition interventions, but I would even argue a lot of your basic health interventions, right? And I think nutrition interventions may even be lower because the health system is not sensitized to nutrition, right? It's almost by chance that somebody actually looked and diagnosed that. So all of that sounds very overwhelming, particularly the social context in which it's embedded. But to me, I actually look at it very optimistically, right? To me, I was like, wow, like this is all stuff that's very fixable. It's something that, like I said, doesn't require a new drug, doesn't require new technology. There's opportunities up and down this whole trajectory of how we can actually do something better. So what would that actually look like? So I think there's 4 ways that I think we can reconfigure health systems to actually address nutrition more effectively. And I would argue some of these approaches would improve how we address the whole gambit of health issues better. Because I think a lot of the challenges for health systems to actually deliver nutrition interventions are the same breakdowns that affect their ability to deliver the wider range of core health interventions and manage cases. So one is to actually shift towards true primary health care. So in most low-income settings, we don't have a true notion of primary health care. And what I mean by that is healthcare that is integrated, where we actually cover the whole range of diseases and not just these 3 or 4 illnesses that come through the door. Secondly, is something where we're actually doing things proactively, right? So what we have in a lot of these communities is urgent care, and in kind of U.S. medical parlance, urgent care is like when you have like my arm hurts, let me go get it seen. It's not let me actually go get checked out to make sure my blood pressure, et cetera, is okay. So I think, we still do everything in reaction, right? And certainly immunization, antenatal care, these kinds of interventions are done somewhat proactively, but actually our coverage for those interventions is still lacking in a lot of these communities, right? And certainly for something like malnutrition, we should be proactively reaching out and trying to recognize these cases, because it doesn't happen overnight, right? These are cases that will get worse over time, and we have plenty of room to actually intervene earlier. So I think really shifting towards that. And I know many of you will know that in a lot of country policies, there already is that in policy, something where community health workers should be going to the household, primary clinics should be staffed at the local level. And I think that brings me to my second point, which is that I think we have a lot of challenges with actual execution. And I think that's probably the biggest arena where we need to improve things. Jishnu Das, who's an economist at the World Bank, has done some studies showing how people who actually get to the facility, how many of them actually get the basic steps of history, examination, and treatment. And a lot of times it's less than 20%. So our performance in systems is actually very poor. And there's a lot of issues with that. I will say one challenge that I see is organizational complexity, which is that we have 100 interventions or so that need to happen through these same clinics with these same 5 staff. And all of those 100 interventions all have at least 10 specific steps to them. And there's not a clear sense of who's going to do which step at what point and how. And then when that happens, it's a little bit ad hoc whether something happens or not. Number one. Number two, there's not support to make sure those steps can be done adequately in terms of having the right quality, the right training. Thirdly, there's no ability to hold people accountable, which I think is kind of overriding. Nobody has any idea of how many kids actually got assessed the way they should have, right? So we don't have a sense of doing that, and that undermines, I think, accountability. Third thing I'd say is this question of being more proactive, I think is particularly important in communities like the ones I'm describing. So a state in southern India that many of you will be familiar with, Kerala, where you have basically 100% female literacy. Their mothers will know which immunizations, for example, their kids need, when, and they'll not only meet the system halfway, they'll show up at the system's door and knock on the door and be like, you better immunize my kid today, right? In other communities, it's the opposite where, for example, Rena's mother knows, okay, my kid needs to get immunized. I'm using immunization as an example, but you can say for any other intervention. But I don't know exactly when, and I'm not empowered to actually force the system to perform. Right? Some of that speaks to broader governance, but I think from a system standpoint, what that tells me is we need to actually be able to chase after each of these kids to make sure we get 100% coverage. So how can we do that? And I think there's new opportunities to do this. We try to do this on paper charts right now, which is just too untenable to actually manage. And I'm not trying to fetishize technology and development, which I think sometimes gets overhyped, but I think technology actually allows us to actually now automate not just registries and keeping track of patients, but also the coordination we need. So it can automatically flag you to follow up. And I think that's sort of an untapped area. And I know some governments are trying to do this. And the last thing, which I'll close with, because I'm probably over time by now, is, there's these systems reforms we can do, which can only go so far until we can actually address some of the broader social underpinnings, right? And that's the question. Like, I'm not going to lie and say there's some simple solution, but I certainly think that things change quickly, right? Like I said, like my father grew up malnourished, and now my nephews and nieces living in the same house, same village, are growing up overnourished or malnourished in the other way, right? And so things are not stuck the way they are. And I think in communities that have traditionally been stuck in a cycle of disempowerment, there's greater levels of education than before, greater connectivity. And I think there's people like us, right? And I think I would argue in India, I think there's enough people, poor and privileged, who kind of see the way things are as intolerable and unacceptable. And I think these things can change, and I think that really just takes acknowledging that they need to change, not accepting the way they are, and then pushing for things to happen. And I think when we start making the system reforms, I think you can have a virtuous cycle where the systems reforms are actually reinforced by people actually being empowered and getting what they need, and then demanding that to be there the next time. So I'll stop there. I'll look forward to any questions you have. Thank you.
Thank you. I think Ranu certainly hit a nail on the head when he talked about girls and women's empowerment and that component in the work and the discussions that we're having here. Does anybody have any clarifying questions? Again, these are just questions based on just teasing the nuances out right now, and then during the discussion we could take it to a broader conversation. No? Okay, so then we'll move on to Frederica Mayor. She's the representative for India and the country director for Bhutan for UNFPA. And I think there's something serendipitous to having Frederica follow after Ranu, and not just because she's also going to be talking a bit about interventions in India, but also because Ranu spoke a bit about disparities within countries as well. When we look at maternal morbidity and mortality rates, and we should celebrate that we have made progress under the MDGs, but there's still that last mile that needs to go, that we need to go, and that's a lot where the marginalized communities folks from marginalized communities that he was referencing are who we really aren't reaching. So Frederica, I also want to point out that Frederica and I have a bit of history together. Also, not through Facebook networking, though. Frederica played a key role in a study tour that I put together at a previous job in India. And then also, for those of you who've been following our series, in April 2013, we traveled to India and partnered with the Population Foundation of India, brought together a team of maternal health experts, and had the rollout of our day-long discussion with them video conferenced in an audience here. So I suspect some of you were part of that. And Frederica played a key role in making sure that video conference in particular happened. It was in the UNFP offices and UN offices that we were actually video conferencing from. So thank you for this long history of working together, and we're really excited to hear your comments.
Thank you, Sandeep, and probably that's too much of honor, what you're all saying there. But it's always a pleasure working with Sandeep, and I was extremely happy when she invited me to be part of this get-together on malnutrition and so on. And I'm a little bit hesitant because I had a story which is In fact, a little bit similar than what Dylan did. However, I'm going to read it out to you because this is coming from the book, which is Us in the Belly, and this was written by Mr. Harsh Mander, and he was the food commissioner in India who was instrumental in the food security bill. And this, I mean, we are talking about malnutrition, but it's also very much about hunger. At the moment in India, there are still between 80 and 230 million people who go hungry to bed every night. And we were talking about how many people in this hall. Well, 230 million. We can think about which country is comparable to that. So I'm going to read this story to you because quite often we only look at statistics without thinking who are the people behind the statistics. Quite often we forget that there are faces behind statistics. So it's a short story. Barely 7 days had passed since his widowed mother, Gaya Lakshmi, had died, defeated finally by hunger. And Balachandra, her 13-year-old eldest son, was still badly shaken. If there was even a little rice in the house, she would force us to eat, he recalled. When Bala would press his mother to share the food, she would reply, "You need more food than I do. My life is done, and it is you who should eat. Become strong, study hard, and grow to be a good man." Jaya Lakshmi was only 32 years old when she felt and her life was over. She quietly surrendered in her brave but unequal battle with hunger. Her husband had died 2 years earlier of a kidney failure. Belonging to the most oppressed Madiga Dalit caste, they owned no land. Even when he was alive, they found work as farm workers only sporadically, and wages for agricultural workers in the Telangana region. Sorry, I should not mention a state, as he said, but this is a book. Of Andhra Pradesh were only half the legal minimum wage for men and a quarter for women. When she did find work, Gaya Lakshmi could not earn more than 25 rupees a day. 25 rupees a day is about $0.50, less than $0.50. Their predicament was compounded by 4 years of consecutive drought because most farmers in their village were forced to abandon their now parched and barren fields. During her husband's illness, she had borrowed 7,000 rupees for the local moneylender. After his death, she would rise at dawn to collect curry leaves and sell them at the village market. Part of her earnings went to the moneylender, part to the owner of the fields, where she plucked the curry leaves. Usually not more than 10 rupees were left a day to feed her 3 small children and each half-blind mother-in-law. Some compassionate local Dalit young men of her village were moved to see her daily struggle to keep her children alive and helped her by securing admission for Balachandra and his 9-year-old sister Ranjani in government hostels for Dalit children. She now had to worry about food for only her older children, only during the school vacations. The younger, Suman, remained with Gaya Lakshmi along with her husband's mother, who had nowhere else to go. The children were sent to the schools because they got the midday meals, and I got back to that. Jaya Lakshmi's strength and spirit slowly ebbed as she often toiled without food for days at a stretch. During her last months, she could not even rise from the frayed straw mat on the dust floor of their hovel. Balachandra dropped out of his school, and a hostel to take care of her and feed the family. He would also spend his days sourcing the fields and gathering and selling curry leaves, like his mother did when she had strength. Finally, life left his mother frail and wasted frame. It is a custom among Dalit Madiga caste of Andhra to tie some grains of rice to the edge of a sari of a woman who dies before she is buried in the unmarked grave. Bala's greatest regret was that when his mother Jaya Lakshmi died, there was no rice in the house. It is considered inauspicious for neighbors to donate grains for funeral rites. So Gaya Lakshmi had to be buried as she had lived, without solace and dignity, and without even a few grains of rice. So when I flew to Washington, I was reading this book, and I must say I would recommend it all to you read it, because there are not a few pages which leaves you without tears. So that's as an introduction of what India is still facing. And it's not a matter that there's not enough food in India. India has overcome food security. There's enough food in the country. It's much more about distribution. So this presentation will go about the conceptual framework, India and the key indicators, continuum of care in India data, intervention, how India tries to overcome malnutrition, and some recommendations. And I want to make a plea here that we need to invest in girls and breaking the intergenerational cycle of malnutrition. And I think just come further to my former presenter, I think investing in girls is maybe the best guarantee that we can overcome hunger. So the conceptual framework, we move now a little bit more towards how it is related to, how do we call it, preconception care and family planning, and how we can work on the continuum of care along all the age groups. I guess we are going to distribute the presentation, so I'm not going to walk you all through the different areas, but at every stage of life, from young children to older, we have to give special interventions. And I guess you as a nutritionist have already given somewhere. But what we also see that the platform, the community delivery platform in the integrated management of care, you will see India is addressing all of these issues, what needs to happen at a certain point of the cycle of, how do you call it, the cycle of interventions. So some key indicators. The first one is immediately wrong because by now it's 47%. Women were married before the age of 18 and 30% gave birth before the age of 18. Half of the adolescents have a below normal BMI. 56 adolescents have anemia. The highest prevalence of anemia is between the age of 12 and 13. Adolescents contribute to about approximately 16% of the total fertility. And this again makes a case on why we have to invest in adolescent girls. 36% of women have a BMI of below 18.5. 1 in 5 of the babies born each year have a low birth rate. Nearly 80% of the children are anemic. And the highest rate of stunting is in India, 30% of the global burden. 42.5% of children are underweight, and the biggest contributor to the world's prematurity death is happening in India. So you can see we are having a pretty bleak picture in India. Also, I'm coming later to that. So what about the continuum of care? We have to have several critical interventions in the preconception care, which is important for pregnancy and child health outcomes, and reduction of preterm birth rates. And you could see, since so many adolescent girls are already becoming pregnant, this is a very important issue that you start your interventions very early. It comes back later on. It's of course very important to the birth rate, important risk factor for child survival and a strong predictor for the size in later life, which was also said by the former two. Undernourished mothers usually deliver low birth rate children. First 2 years of life, a critical window of opportunities for prevention of this area. The undernutrition epitomizes social inequities. And this is also, I mean, a lot of low birth rate children are born to women of lower caste, etc. So they are already disadvantaged, and you can see that the disadvancement of those children is going on and on. If you are malnourished in the early ages of life, you can hardly catch up. You don't have the ability to learn well in school. So it continues from generation. So it's really the intergenerational cycle of poverty. Also, stunting serves as mark for poverty and underdevelopment. The intervention should really focus on the first 1,000 days. And what I said before, it's the intergenerational cycle of survival, growth, and development. Undernourished girls become undernourished women who give, again, birth to the next generation of undernourished children. Also, preconception care in India, and we know that's before. In the age of 11 to 18, adolescent girls, 16.75% of the female population. Approximately 1 in 3 adolescent girls are undernourished. These are some of the repetition which I've said before already. Child nutrition, 22% of the births are for below birth. 42% of children 0 to 5 are underweight. 79% of children are anemic. Okay, I will give you these slides and you will see all the data one more time. So gender and nutrition, I would say this whole issue of undernutrition is very much the feminization of undernutrition. We know in India, women are the last one to eat in many societies. So even if there is enough food for a family as a whole, the woman is the last one who gets it. So even the food which she gets is quite often of a much lower quality. India is providing for several interventions where they, for example, for lactating mothers and also for pregnant mothers, they get rations to take home rations. So what happened to those take home rations, the mother takes it, but first she has to serve the whole family while the food was meant for her, and she's then the last one, if something is left, that she's the last one who gets it. So with the interventions, we really have to look very well on who is the woman who needs the food the most, and how can we prevent intervention that she maybe can eat at the centers where she is receiving the food, or can we have all kind of different mechanisms to make sure that she really gets it. Also, women are the highest one who drop out from school. There is evidence of the low status of women in the household. And of course, there's women's lack of decision-making power and control over income, which also have an adverse effect on health-seeking behavior in child health and nutrition. For example, what we just heard, the girl child, what was happening to the Dalit mother. Very often, women cannot go out of the house, and so when they have a sick girl child, the father quite often, unfortunately, is not even bringing him or her to the health center, because the value of the girl child is so low, and sometimes they are even a kind of relieved when they are not surviving, which is a very hard statistic. But a lot of families see the girl child really as a big burden, because they have to pay dowry. So from the poorer families, the sooner a girl is not there in your household anymore, the better off you are quite often. So it's not only the gender issue in nutrition, it's also quite often it's the caste, which is very close related, which we saw already, but it's also very much a religious issue. We know that some religious people are getting less access to the places where they have to get food than other religions. And it's also quite, if you are disabled, you are the worst off. So this is the whole cycle of discrimination. It gives you here several stages on what preconception, where the discrimination starts already, then at the infant rate. So along the whole cycle of your life, women are very much discriminated. So what is the India response, which might be more interesting? India has many, many schemes at all kind of different levels. So this is more an illustration of what all the different schemes are for women and for children to overcome this malnutrition. But what we have seen, it's not an issue of availability, it's more an issue of accessibility of the many schemes. India also has last year made a call for action on the RMNCH&A. I'm not sure whether you're all familiar with RMNCH&A. This is a program which is really looking at your continuum of care, where you look from family planning issues to lactating or to nutrition issues. It's a whole package where the health system is responding to the reproductive, maternal, newborn, and child health care. Quite recently, India, together with UNFPA, has added the A to the RMNCH, because we think the best investment is on the adolescent girls. Okay, this I'm not going through. So why investing in adolescent girls? We know that if you are not in school, if you are dropping out of school, then you have very little agency to have decision-making power, and you are already far behind. In addition, India has the biggest adolescent group in the whole history right now. There are 253 million adolescents in India, and the government is really willing to invest in them. And so beginning of the year, we launched this program. It's the Rashtriya Kishore Swasthya Karyakram, and we call it RKSK. And the Ministry of Health has launched it, in which is focusing on the age group 10 to 19. They look at 6 priority areas, of which nutrition is a very important area, but also mental health, violence, substance abuse, SRH, and non-communicable diseases. We also realized that one size doesn't fit all. For example, what we heard from the presenter, we have the issue of obesity and we have the issue of undernutrition. So we really have to fine-tune all our strategies and look at to which population group we are addressing certain issues. We are moving a lot away from clinical approaches, so that was an interesting approach you gave, to more health promotion. Can we give to the children who are obese, to tell them that eating a hamburger every day is not the best healthy choice, and also telling their parents and talking with them through why they should give them more nutritious food. And on the other side, we have to make sure that people who are undernourished, that they are having more access to food distribution. So they have to take home rations on hot cooked meals, what we already said. So the out-of-school girls from 11 to 14, they do eat at the center. So they get some food over there, but still the home they take, or the food they take home, it's not often that it comes to in their stomachs. How much time I have now?
About 5 minutes.
Okay. I'm skipping this through because I want to focus on another area where we're coming to. So we also have the sabla and the midday meal in India. So the sabla is specifically looking at adolescent girls who are in the villages and really talking through with them on how can they raise their families in a more nutritious way. And we have, since last year, we have hot cooked meals at the schools. Before it were quite often cookies and tea, but since the last 2 years we have hot meal cooks at school, which is improving a lot. Here you see the big numbers of India, which is always the challenge in India. If you have to do an intervention, you have to deal with millions and millions. So UNFPA was last year involved with a launch with the government, which was called WIFS, and which was really looking at iron folic acid. We made a big media campaign with the government, which was looking very much at how can we make people taking more iron folic acid tablets. Because before everyone was saying, well, these tablets make us sick. So what can we do? Because they start vomiting and so after this tablet. So there was a lot of myth that you shouldn't take this tablet. While at the same time we know that the huge anemic prevalence in India, we have to address these issues. So we started with a campaign, a launch of posters, wall planners, launch events, etc., etc. And what we called it, it was Solo Bano India. So the campaign was very much focusing on that you need this iron folic tablet also to strengthen your brains and your body at the same time. So it makes you more healthy. It's not that you are sick, but it makes you more, how do you call it? And I'm going to show you a little clip here. Here?
Yep.
Yeah, so before it starts, it's about a teacher, because it's in Hindi, and I don't know how many people speak Hindi here, but it's about a teacher who is asking a class, what do you eat first? Do you first eat a chapati, or do you first take the iron folic tablet? And that's, I will ask you in the end what it was.
वर्ल्ड भर में क्रिकेट में सबसे ज्यादा सेंचुरी किसने बनाई है? अरे चुप! अगला क्वेश्चन कौन आंसरेगा? पराठा या आयरन की नीली गोली? पहले क्या आता है?
क्या होता है? तुझे मालूम है आंसर?
जो सही जवाब देगा वो ये पराठा जीतेगा. सोचो.
सर का ना सर घूम गया है.
मामूली पराठा नहीं है, जैम पराठा. कौन जीतेगा ये पराठा?
ये कौन से सब्जेक्ट का क्वेश्चन है? साइंस की बुक में नहीं है.
टाइम ओवर. पहले आता है पराठा, फिर आयरन की गोली. यानी आयरन की गोली लेने से पहले कुछ खाना जरूर, खाली पेट नहीं. तो अब जैम पराठा कौन खाएगा?
बनना है एकदम सॉलिड तो लो आयरन की सिर्फ एक नीली गोली हर हफ्ते, मगर खाली पेट नहीं. सरकारी स्कूलों और आंगनबाड़ी केंद्रों में निःशुल्क उपलब्ध. सॉलिड बनो इंडिया, भारत सरकार की पहल.
Good, so that was the spot we... what made all the difference? There were a few things. We worked a lot with teachers on telling them why it's so important to first eat this... Oh, sorry.
वर्ल्ड भर में क्रिकेट में सबसे ज्यादा सेंचुरी किसने बनाई है?
To talk with the, there is not a PowerPoint, to talk with the teachers why it's so important to eat first this chapati and then the tablet. The other thing what we also did, or together with the government, is making the teacher first swallow the tablet himself. So that you are telling everyone that this is a safe tablet. So at the same time, the teacher might not know it, but it also wouldn't harm him. He swallows first the tablet in front of the classroom and then all the students are following. Unfortunately, what we did not do was making a baseline on whether it really changed with biomarkers, etc. But I'm not a doctor, I'm a sociologist. To see whether it changed the biomarkers of the children, and the government also didn't do it. So it remains to be seen. It's now half a year into the program. It remains to be seen what the exact results will be. So that was the answer. So the progress, what we said, was satisfactory so far. Why we say satisfactory? Because everyone is taking it. Okay. So it was a community-based intervention, and it addressed a lot of nutritional anemia among both boys and girls. So the intervention is at a quite a young age, 12, 13 years, and that helps. Okay. It's okay. It's not fine. So what needs to be done in India about nutrition, in our view? I mean, we really need to focus far more on linking the continuum of care. And I haven't touched that issue yet. We have to make sure, first of all, that adolescent girls are not dropping out of school. That's for issue one. Then also, since there are so much at the age of young age producing children, we have to make sure that we first delay the first child and also space the second child very much, because we see that in a lot of cases, young people don't have access to family planning. And of course, I'm from UNFPA. We find it the most important issue that people have access on information, but also on commodities of contraceptives. So the frontline workers in India are now very much trained on providing contraceptives at the doorsteps of family, but this can only be married adolescents. So the unmarried adolescents have very little access. However, for this poorest income quintile, it's quite often those young women are married before the age of 18. So if we're already reaching that group, that would make a big change in challenging malnutrition and so on. So we focus a lot on providing youngsters information, delaying first marriage, delaying first pregnancy, spacing second pregnancy. That's within the RMHCH framework. That's the most important issue what we are working on. And the government is very much with us. So we hope together with the government, strengthening the system. But we believe more in prevention, keeping them out of the health system than in the health system. Because India has now 600,000 frontline health workers, women health workers, and they are bringing a lot of services to the doorstep. So, for example, in monitoring child malnutrition, these workers, I mean, they are not really health workers, they are volunteers, but they can play a big role on providing more access to everyone who doesn't have access right now. And with this, I would leave it to the next speaker.
Great, thank you. I know Frederica quickly discussed this, but perhaps we can talk about it more in the discussion. But the healthcare workers that you're referring to, the volunteers that go into the community, I think that dovetails really nicely into some of the discussion we were having, or the comments that were made by Ranu about reaching marginalized communities, because I think that could be one way to expand services. Speaking of expansion of services, I know that with our remaining speakers, we'll hear a little bit more about working with adolescents in that preconception phase in particular. Before we move on to them, I just wanted to quickly mention, I know that Frederica had a lot of valuable information in her slides that she didn't get to. So we don't have the PowerPoints printed out today because we are also members of the Environmental Change and Security Program. So instead, you can access them online. So when you visit our website and you click on this event at the bottom, everybody's PowerPoints will be available there. And for those that didn't have a PowerPoint, you can also take notes again from their presentations because the video will be available. So let's now move on and hear some comments and thoughts from Corey Mazo, who's the Health and Nutrition Office Advisor, for Child Fund International.
Thanks, Sandeep. Hi, I'm Corey Mazio. I'm from Child Fund International, and I'm going to talk a little bit about our approach to maternal, newborn, child health and nutrition across the continuum. So just to give a little snapshot of who is Child Fund, because I think a lot of folks might not be familiar with us. We were previously called Christian Children's Fund. We changed our name in 2009. We're part of an alliance, the Child Fund Alliance, which is made up of 12 member organizations, and together we serve over 15 million children and their families in 58 countries. Child Fund International works in 30 of those countries, and our mission is to help deprived, excluded, and vulnerable children have the capacity to improve their lives and the opportunity to become young adults, parents, and leaders who bring lasting positive change in their communities. So a little bit about our overall approach. We work with local partners to create sustainable solutions that are child-focused and community-based, using a framework of evidence-based strategies. And we're really focused on the interconnected nature of children's needs, so putting children and families at the center and recognizing that they don't have just nutrition needs or just education needs. They have a whole set of multifaceted needs that are all intertwined. and those all have an impact on their overall development and long-term well-being. And we are historically a child sponsorship organization, so a good part of our funding comes through child sponsorship, but we also have grant-funded projects. We work with USAID, and we also have foundation donors, major individual donors, corporate donors, etc. So our program development division is broken up into 3 life stage teams. I sit on the life stage 1 team, which focuses on this conception to 5 period, infants and young children, but because we're talking about all the way back to even before birth, we're also working with mothers and parents. And across the 3 life stages, each life stage has a theory of change that they work with, and that addresses the key domains and pathways that facilitate change during that life stage, and then also into the transition to the next life stage. And in all of the life stages, we promote the roles that children themselves have, and also parents and caregivers, community members, and society as a whole, the roles that they have in supporting children throughout the life stages and at those key critical transition points between the different life stages. For life stage 1, we place a major emphasis on the first 1,000 days because we know that that is a really critical window, particularly when we're talking about nutrition, as we are today, but also for early childhood development. So early stimulation and responsive caregiving, we place a major emphasis on that in the first 1,000 days, and then extending through to the 5-year, the age of 5 years, transitioning into primary school. We also work backwards with life stage 3. So life stage 3 is focused on youth, adolescents and young adults. And we've talked a lot about this. Frederica and Ranu both brought up the issue of sort of preconception care. And so we know evidence is really starting to tell us more and more that it's not just what a child eats after he's born, it's starting during pregnancy. We know that 20% of stunting starts in utero. And so going backwards in that preconception care, even before conception, a woman's nutritional status can have an impact on the subsequent child development. So this is sort of the guiding question for life stage 1. What is it that infants and young children need to survive and to thrive and to be secure and healthy and to grow up strong? And so we work with this theory of change, and we're in the process now over the last year or so of going out and working with the different country programs in our national offices to contextualize the theory of change for each individual context based on what the situation and needs are there. So this is a graphic that actually one of my colleagues, Melissa Kelly, worked on with our Uganda team during a workshop, and we've sort of tweaked it a little bit. It's still being refined, so it's not something that's really final. It's a work in progress, but you can kind of see we put the child at the center, and children have all of these interconnected needs. They overlap. We can't separate nutrition from early learning, from health and hygiene, from protection, and then they extend out into the family's needs, the caregiver needs, and then also the community at large. This is a snapshot of the 4 domains of our life stage 1 theory of change, and the 2 that are really most relevant to our discussion today here is the idea of having empowered responsive caregivers and having high quality healthcare and nutrition for mothers, infants, and young children. And one thing that's interesting to note is I was in Senegal last month with some of my team members doing one of these contextualization workshops on the theory of change, and we got into a pretty detailed discussion with the team there about this third one, high quality healthcare and nutrition for mothers, infants, and young children. Because the language before it was translated into French had said expectant mothers, and so it was translated to be future mothers, and we had this discussion around, well, really, aren't all women future mothers potentially if they want to be? So we really shouldn't just be focused on pregnant women, we should be focused on all women. And that means we should be focused on girls as well if we're going back and trying to make sure that girls are healthy, that they have the nutrition, the health care, the education, all of the things that they need so that if and when they choose to become mothers, they're prepared. So why the focus on caregivers first? Why is that first domain? We know that empowered, responsive caregivers really create that foundation for healthy child development. Caregivers can include mothers and fathers. It also includes other siblings. It includes grandparents, other caretakers. We do know that it's important for a child to have one primary caregiver, and so that oftentimes is the mother. But really, one of the things that we emphasize is working with the family to identify a primary caregiver and ensure that that person is well equipped with the knowledge, the skills, the resources, and also the decision-making power to utilize those resources. So just because you have access to food, for example, doesn't necessarily mean that you have the decision-making authority within your household or within your family to distribute the food. The example of women eating last, for example. So working with families, working with caregivers around those sort of relationship dynamics and gender dynamics. We're all very well aware of the link between maternal health and well-being and maternal survival and child survival. We don't need to go into that, but in particular, we know maternal nutrition before and during pregnancy plays a major role. Like I said before, that 20% of stunting that starts can be attributed to IUGR growth restriction during pregnancy. And we know that low birth weight is a major contributor to newborn deaths. And then another area is maternal mental health and child nutrition status. So there's more and more research coming out that points to this association between, for example, maternal depression and child undernutrition. It's an area that certainly needs further investigation. There are a number of partners. We've been chatting with different partners. For those who might have been at the spring core group meeting, or there was a TOPS FSN knowledge sharing meeting a couple weeks ago, there were some folks talking about this in some of the presentations, that there are some integrated interventions being tested to see how do you intervene and promote maternal mental health while also addressing the nutrition of mother and child. So what do caregivers need? They need a lot of the same things that children need. We're all human. We share a lot of these needs throughout our life course. They need resources, including knowledge and skills. So they need support for livelihoods. Food security is a major issue. So not just having the availability of food, but the access to the right kinds of food. Parenting education and support is sort of our bread and butter. We do quite a lot of that. And then health and nutrition services. We want to make sure that people have access to those for themselves and also for their children, and that they are of high quality. Decision-making power is another important piece for caregivers' needs. So we work on issues around women's empowerment. We work on male partner and father engagement. We know certainly it's sort of obvious to folks what the link is between a mother and child and that relationship, but fathers also have a very important role to play in the caregiving and attachment relationship with children, and so we work around that. And then the caregiver relationships and dynamics that come into play there around decision making in the household. So this is not by any means an exhaustive list, but just an example of some of the things that we do across the continuum, from adolescence and the period before pregnancy, through pregnancy and birth, and then postnatally, so for mother and for child. And I'll get a little bit into an example from Senegal that works on all of these issues. But you can see, there are a number of issues, and then these issues around food security and livelihood support, WASH, and then women's empowerment and male engagement sort of cut across during all of the different time periods. And certainly that early stimulation and early childhood development would also sort of cut across the whole thing. So just a quick example of our work in the fields. In Senegal, we have a project called PSSC2. It's an integrated community health project that is nationwide. It's a USAID-funded 5-year project we implement with the partners listed here, and we work very closely with USAID and the Ministry of Health in country. It's an integrated project, which means it has just about everything you can possibly imagine. We work on a whole bunch of different health, nutrition, development issues. It works in all 14 regions of the country, reaching over 9 million people, and these are people who primarily rely on the lowest level of the health system for their primary health care. So if you're not familiar with the Senegal context, health huts were previously the sort of unofficial, they weren't part of the health system formally, but they are the lowest level of care. They're in communities, and part of what, a major part of what our project is doing there is working on bringing those into the formal health system. There was recently a community health policy that was passed in Senegal, and that formalized the relationship of health huts in the formal health system. And then we're working with health huts to graduate them, to make them part of the local system and the health system, so that they are managed by the community and by the district health system. So the target population for the project is women and children, ranging all the way up to school-age children. We work in collaboration with a number of national and local partners. We work with the PRN, which is the Nutrition Reinforcement Program in Senegal. That's funded by the government of Senegal and the World Bank, and also with USAID's Yagende, which is a Feed the Future initiative in Senegal, to work on both nutrition-specific and nutrition-sensitive interventions. So nutrition-specific, I've listed some of the things that PSSC provides as part of the integrated package, and then also some of these nutrition-sensitive approaches and interventions, family planning, WASH, women's empowerment, and then ECD as well. So just two examples. This is a picture. I really like this picture. At a lot of the health huts, they use very low-tech IEC materials, information, education, communication materials that are developed by the teams at the health huts. So they don't have these big, fancy, shiny printed posters. They make stuff there, and then when it has to be updated, they update it themselves. So this was a picture that was at one of the health huts, and my colleague Sarah took this photo. So just two examples of nutrition activities that PSSC is working on. They have these pregnancy solidarity groups, these support groups for pregnant women, and they talk about a whole host of issues, including good nutrition during pregnancy and lactation, and optimal infant and young child feeding, so breastfeeding, as well as the introduction of complementary foods. And they also do cooking demonstrations and, I'm forgetting the English word, but sort of home gardening, to teach families how to prepare their own foods, use locally available foods, so that they're not necessarily going out and buying some of these cheaper, less nutritious foods that are available in some of the areas where we work. So what's next? One of the things that we're really excited about at Child Fund is the new USAID multi-sectoral nutrition strategy. The recognition that nutrition-sensitive interventions also have an important role to play in reaching nutrition goals, because a lot of what we do is not that nutrition-specific. The Senegal project is sort of the exception to the rule, because they do quite a bit of specific health and nutrition work. But we really work in that nutrition-sensitive, nutrition-enabling environment in the education sector, outside of the health sector specifically. So one of the things that we've talked a lot about within Child Fund is this idea of more intentional integration. You know, integration, I come from a health background, worked on family planning and HIV and nutrition things for a long time, and there's a lot of integration talk. And sometimes it works and sometimes it doesn't, but there's always this question around how do you really do it well? And one of the things that we're really thinking about at Child Fund is, because we're set up in this cross-sectoral way with education and ECD and nutrition and health, how do we bring those things together? And how do we do it in a way that works for the system, that works for health workers, that works for families and individuals, so that we're not overburdening the system or the individual caregiver or parent? And then this question around, we think that integrated interventions are better, but are they? And do they have an effect on caregiver practices? Do they have an effect on caregiver well-being? So questions around that and being very intentional about how we design these integrated approaches and really testing that out in different contexts. And then finally, this area of articulating that transition between life stage 3 and life stage 1. So going from being an adolescent or a young adult, particularly for young women, how do we work with that transition to make sure that it's meaningful and strong? What are the approaches that are needed there? One example is this future parent group in Senegal. They have these future father groups for young men to start engaging them around issues around caregiving dynamics, around how to be a strong, present father and be involved in their children's lives, and also how to support their partner, their wife, and the things that are needed for a strong and healthy family, starting even before you become a parent. So really thinking carefully about what do those transitions look like? What are the approaches? What are the interventions that are needed there to make sure that that's happening well and that we can support young women as well as young men as they grow up into strong, healthy adults and potential parents. So thank you.
Corey did a really good job of making the wheels turn, especially around the integration discussion, whether it works and how to do it well. In particular, I think your comments around integration around maternal mental health, as well as integration with male partners and father engagement were really good. And I have to say, I know we've been talking a bit about girls and women's empowerment, but none of that's going to happen effectively, at least in my humble opinion, if we don't involve the male partner or the fathers in these discussions. So let's move on to our last but not least speaker, Tanuja Rastogi, who's a senior policy advisor at United Nations World Food Program.
Thank you. Thank you, Cindy. First of all, I'm very excited that the World Food Program was invited to this, what is a predominantly health panel. What I will do today is provide a brief overview of WFP and our, increasing attention on the issue of maternal nutrition, and as a very large organization too. So. Many of you guys know the World Food Program. It's the largest humanitarian agency fighting hunger worldwide. We reach approximately 80 million children, 80 million beneficiaries in 75 countries. That was in 2013. We have a food assistance mandate. Over the last few years, we've made a major organizational shift from food aid to food assistance. Our core focus, of course, is on emergencies, which many of you have heard of the major emergencies we're supporting in South Sudan, where we're reaching upwards of 3.2 million beneficiaries this year. In Central African Republic, we're aiming to reach 1 million beneficiaries. And in the very complex operations in Syria, we're reaching upwards of 7 million beneficiaries, 3 million of which are refugees in neighboring countries. We also work very closely in communities to build resilience and support nutrition. We work in schools to support national government school feeding programs. Last year, I think we reached approximately 20 million school children, and we support targeted nutrition programs and reaching upwards of 12 million children and 4 million pregnant and lactating mothers. We spoke about India. In some countries, we actually don't even bring in food. We provide technical nutrition support or technical food security support, such as helping them with providing support on the targeted public distribution system. In Egypt, we work to support the fortification of their national Baladi bread program in partnership with other important nutrition groups. WFP, we've really focused recently on ensuring adequate nutrition for mothers and young children. We've heard before that the magnitude of the problem is very, very high. Nearly 50% of all child deaths under the age of 5 can be attributed to undernutrition. 52 million children are considered, quote, wasted, which is meaning too thin for their height. And 165 million children, we heard earlier, are stunted, or 1 in 4 children in developing countries. The Lancet Maternal and Child Nutrition Series in 2008, as well as again in 2013, really emphasized the importance of addressing proper nutrition during these critical 1,000 days. Inadequate nutrition during this important period from conception to the age of 2 leads to not just physical impairments in growth, but also cognitive development issues. And we've seen that often translates into poorer learning in schools, in children in schools, which, based on research, has shown that an impact on future earnings. And economic research indicates that countries with high levels of undernutrition have upwards of 2 to 3% reductions in GDP. Now, WFP, over the past 5 to 7 years now, has really accelerated its focus on nutrition because of, this new evidence, but also, 2, because of the development of specialized nutritious foods that we can use in a lot of our delivery operations, as well as food technology support that we can give to local manufacturers to locally develop more nutritious foods that contain the right levels of micronutrients as well as macronutrients. In 2012, we reached upwards, as I mentioned, 4 million pregnant and lactating women and 12 million children in nutrition programs. So WFP, what we try to do is we target our interventions to maximize the nutrition impact of the foods we give. We tailor our responses based on the nutrient gap in that particular population. So there are many causes of undernutrition. I just want to make sure I make a disclaimer. It's not just food, clearly. We don't need to tell that to this audience. WFP, our mandate is really to focus on the inadequate dietary intake with our nutrition programs, and also addressing some of the underlying issues of access that we've heard about before. But we work very closely with our partners to make sure issues such as diarrhea and clean water and wash are also included in these programs. WFP's mission in nutrition is to work with partners to fight undernutrition by ensuring physical and economic access to a nutritious and age-appropriate diet for those who lack it, and to support households and communities in utilizing food adequately. So in these last 5 years, the major shifts that we've done in terms of programmatically, we've shifted from focusing on a treatment of undernutrition to also focusing on prevention, with the aim that if you continue focusing on prevention, the levels of needs for treatment will go down over time. We're also increasing our focus on targeting better. Again, we're focusing on the 1,000 days, but as well as the 1,000 days plus period, which is very important in terms of capturing adolescent girls to making sure their micronutrient status is adequate, as well as targeting toddlers, preschool children, and as well as children in school feeding programs, as well as adults who are vulnerable to malnutrition, such as HIV/AIDS and TB patients. We're also working on nutrition-sensitive programs, which is what we just heard about, making sure our school feeding programs are providing micronutrient-fortified foods. Skip over this one. So again, the Lancet 2013, which just came out last year, really highlighted the importance of improving nutrition during pregnancy as well as during the pre-pregnancy period. It's essential and vital, as we just heard, is very important in early fetal development, infant survival, as well as birth outcomes. Small for gestational age accounts for upwards of 20% of stunting. Research also showed that food support, particularly in the last trimester of pregnancy, in food insecure areas, has been an effective strategy to reduce stunting, in addition to the complementary foods from the 6 to 23-month period. Now, based on this new evidence, WFP is really increasing its attention on making sure that we address the micronutrient deficiencies in adolescent girls, supporting women, pregnant women, particularly in that last trimester, and supporting the nutrition, caloric primarily, needs of lactating women, through the provision of good quality nutritious foods also to 6 to 24-month-old children, and also, as needed, treating moderate acute malnutrition and preventing acute malnutrition, particularly in settings where there's an acute crisis. Now, we recognize that partnerships operationally is absolutely necessary to do this. You know, WFP, we know that we have to accelerate our focus in our existing programs to target this particular groups, but also that we need to work with other partners to reach these health platforms more effectively. So the theory of change is of course that if you improve nutrition for adolescent girls, you improve nutrition during pregnancy, you'll reduce stunting and small for gestational age, as well as ultimately lead to some reduction in maternal and newborn mortality. Now, for adolescent girls, it's essential that food and nutrition support be provided, but also working, as we've heard, on ensuring that that we delay marriage as well as age at first birth. This is, of course, in conjunction with all the important UNFPA programs and other programs that NGOs are doing and focusing on life skills as well as livelihood activities. Now, adolescent girls, this diagram shows on the bottom, like how do we reach these girls? In terms of partnerships, WFP could bring to the table our work in the area of school feeding, because we work with such large scales with national governments and getting into their school feeding programs. Schools could be a very effective platform to bring nutrition education to adolescent girls, as well as other projects focused on community-based girls groups, facility-based approaches. Now, pregnant women, of course, the primary channels to reach these women will be through antenatal clinics or the health platforms, but there are other channels such as maternity waiting rooms. For us, what we see as an advantage with WFP is that we could use often the food and nutrition support that we bring to the table to increase adherence to antenatal care visits. This is something that we've done in the area of HIV/AIDS, where our support in terms of food and nutrition has actually improved adherence to antiretroviral therapy. So again, that's a nice intersection between a health and a food systems approach. So our executive director, Arthur Cousin, and our director of nutrition, Dr. Martin Bloom, over the past year, or even more so, has prioritized meeting the needs of mothers and adolescent girls. And so at the global level, again, this is really at the global level, we're really focusing on a new partnership with UNFPA and UNICEF to make sure that adolescent girls, pregnant and breastfeeding mothers get the nutrients that they need. The new partnership aims to work through existing platforms such as the H4+, as well as the Adolescent Girls Initiative that UNFPA supports. And as I mentioned earlier, this is very similar to the work that WFP does in the area of HIV/AIDS. So we work with national governments to bring the food and nutrition component to the treatment protocols that are being provided. This is both to support their care and treatment, but also as a social safety net, because patients who are often losing income because they're not able to work. So we also provide food provisions to the household. So it's a nice combination. We've reached approximately 1.5 million HIV and TB infected persons last year through these programs in over 33 countries. So it is a good model for us to bring these two areas together. Now, our technical teams, as we speak, are currently working on a proposal to pilot this approach in the area of maternal nutrition in a variety of countries, and we hopefully have in a year or two some nice anecdotes and innovations that we've heard today, and so we hope to share those in the future and hopefully have some of the lessons learned incorporated across our organization. And given that we have such a big footprint in what we do, we do feel that this can lead to a real important, potentially step change improvement in maternal nutrition and child nutrition. Thank you.
So I think the NUJA really prepped us for the discussion component of this by talking about the importance of partnerships with traditional and non-traditional sectors. I know one thing that we actually heard a bit from Corey as well was around working with folks working on water and sanitation hygiene programs in particular and how it relates to this work. And I think your opening remarks summed us up well too in terms of mentioning that there are health and non-health sector ways to collaborate around these issues. So I appreciate you all sitting through this panel. It's a bit larger than we normally have, but I think all the perspectives are really important. So why don't we open it up for the discussion? Like I said, please do use a mic and introduce yourself and affiliation. Does anybody want to kick us off in particular? We have a question in the back.
Hi, Jordan Teague from WASH Advocates. And I just wanted to thank the last two presenters for bringing in the nutrition-sensitive approaches to this multisectoral issue and for talking about water and sanitation and hygiene, as that's what we focus on at WASH Advocates. And so I wanted to pose a question to the other panelists to see how you see nutrition-sensitive approaches working into the work that you do.
Why don't we try to get a couple questions and then we'll move on. Do we have one on this side?
My name is Reshma Naik. I'm from the Population Reference Bureau. My question is for Frederica and Corinne. I'm currently working on a couple of projects where I'm looking at the links between family planning and nutrition. And I was just curious to actually hear a little bit more about the programming that you know of on the ground that's drawing those links, as well as sort of your sense of what the understanding is on the ground about the links there amongst providers and even the general public when we're looking at those issues.
And perhaps we'll grab one more before we turn it over to the speakers. Okay, why don't we turn it, oh, wait, there's one in the back actually, by the camera.
Hi, I'm Leslie Oot with FHI 360. Thanks so much for quite an array of very interesting presentations. I think one of, I forget who mentioned it, but one of the issues that I think, at least for me, is sort of new is addressing maternal depression and the linkage to nutrition. And I just want to know if there's if there are any specific projects that are working on that, and what sort of, if there's any existing evidence about, you know, what people are doing, what's working. I haven't heard a lot about what is working, so I'd be interested to hear anybody's thoughts on that. Thanks.
So it looks like we have questions or comments for everybody, so perhaps we can just go down the line if that works for you all. We have questions around nutrition-sensitive approaches, the links between family planning and nutrition, and then a question wanting more information about maternal depression and nutrition. So Justine, do you want to kick us off? Does going down the line work for you all then? Yeah, they're on already. Just have to.
Yes, thanks so much for those questions. I think I'll address the WASH question first. You know, I think there definitely needs to be more work done around WASH and nutrition. For Egypt in particular, we actually didn't purposefully collect any information on WASH. However, we know that often hand washing is done, but without soap. And in some countries, people often wash their hands, especially Muslims, before they pray. But we don't have that much information on whether they use soap or not. Anecdotally, we've seen that they haven't been. I think for WASH, I think one thing that's important that's related to child feeding is that mothers often withhold food when a child is ill, and after a child is ill, they don't resume feeding necessarily right away. And it's really important that mothers wash their hands during food preparation and when feeding children when they are ill, and integrating that message along with feeding to make sure that children do stay on track. Because once they have recovered from their illness, we need to make sure that we're supporting their growth adequately. In terms of family planning and nutrition, the MCHIP project is the flagship project for integration, and we have a follow-on called Maternal and Child Survival Program, which is the follow-on flagship, USAID flagship program, where we do integrate family planning and nutrition messages. Particularly, some of the work we've done is in Kenya, in the Bondo district, integrating messages on breastfeeding and lactational and amenorrhea. And also talking to mothers about birth spacing for 2 years. Evidence has shown that with shorter birth intervals, less than 24 months apart, children are at decreased risk of stunting. So this is an important message to get out there, that mothers understand that birth spacing and protecting themselves from pregnancy also affects the growth and development of their children and whether they're at risk for chronic malnutrition. Was there another question?
It was around depression, I think that.
For depression, there has been some evidence on maternal anemia and depression during the postpartum period, and mother and infant attachment. Those women who are anemic are more susceptible to having depressive symptoms. There's been some studies on that. I believe the author is Bodnar, Lisa Bodnar from UNC, has done some of that work in U.S. population rather than in other countries.
Yeah, so this question about integrating WASH and nutrition-sensitive interventions, one thing that I can clarify, I think when I speak about health systems, and I think increasingly the way the discussion around health systems is evolving is a broader notion than just service delivery. Going back to even Alma Ata, the Declaration for Primary Health Care, the vision was actually something that was more integrative of social determinants, certainly some aspects of service delivery, and then public health kinds of approaches. And I think that notion is being revived. And one thing that's actually driving a bit of that is actually the emergence of chronic diseases now, which you really couldn't actually manage just through a reactive service delivery approach, because so much of even someone's ability to be adherent to long-term medications, much less diet and other factors that go into controlling diabetes, high blood pressure, require a more sort of wraparound kind of an approach. And something that's really emerged in the U.S. discussion is this terminology of population health, which is, in some sense, talking more about whatever it takes to actually improve health, and then sort of secondarily looking at what are all the interfaces to do that. And I think we can increasingly take that kind of approach towards how we evolve systems in low-income settings. There's some work that I can talk more about if people are interested that we're building in Madhya Pradesh, one of the poorer states in India that I will name. So one of the poorest states in India, where we're actually trying to actually figure out how that would actually work on the ground level. Because at the end of the day, community, not only do we care about indicators and outcomes at the end of the day, communities themselves are not going to sit there and figure out, okay, let me go to this clinic for my blood pressure, this one for this other problem. They just see these are my issues, and how do I interface? And I think even in the limited conception of health systems as they exist now, like delivery points, clinics, etc., I think there's a greater role they can play in terms of linking people with the other needs that they have, even if it's not something that's delivered through the health system. So this question about WASH in particular, some of you already probably know in India there's this whole discussion about how much open defecation is contributing to undernutrition, and how severe of an issue that is, and how are we going to actually take it on. I think at the ground level, you actually have to have, you'll have cases that come to the health system, and it's a great opportunity to actually figure out which of these other broader public health, social determinants issues are not being adequately addressed, and then linking towards maybe other programs, or in instances where other programs don't exist, actually expanding the notion of what the health system is doing there. I think to some extent in India, the National Rural Health Mission has sort of been doing this a little bit already, where increasingly they're layering on, malnutrition programming and other features. So I think that needs to be done better and more cleanly, and I think there's opportunities in low-income settings and low-income countries to do that in a way that we've actually struggled to do well, I think, in high-income countries, because I think here a lot of things evolved sort of ad hoc, and now we're retroactively trying to reconfigure what is the notion of health and how does it interface across different seemingly separate sectors, whereas I think in low-income settings we have the opportunity to evolve the systems in the first instance to have that in mind. And then this question about maternal depression, I can speak less specifically about maternal depression than mental health as an overall issue, which I think, across the board we've really not addressed effectively in low-income settings. A lot of that has to do with some of the same challenges I was talking about earlier. One aspect is taboo and even the appreciation of mental health issues. Secondly, any conditions that require long-term care with ongoing coordination and frequent adjustment of medications, we have not taken on and done well on. So our examples for quote-unquote chronic disease management in low-income settings are HIV and TB, for example. And certainly there's a lot you can learn from those two. But these are conditions that treatment, the choice of, I think about things from a very process standpoint, almost like engineering. The treatment is binary, treat, don't treat, and then it's a fixed regimen. For mental health, and same thing with hypertension, diabetes, and all these other conditions, what we're now talking about is maybe treat, maybe don't treat, or maybe next month I will have to treat because then your pressure is higher, or your sugar's off. And then it's frequent dose adjustments, which we can algorithmatize to some extent using evidence now. But certainly for something like diabetes, you have to have more nuanced adjustment. And drawing that analogy back to mental health, I think this is something that even in high-income settings, we've not done well to actually protocolize management, which is what I think thinking about trying to implement this across scale is going to be a huge challenge. But I think it's also a huge opportunity to learn how we can actually develop processes that can do that more effectively, and also have an evidence base where we can start figuring out how you can have structured guidelines so that you can initiate treatment without as many specialists. So I think there's a lot of ideas on how to do that better.
Thank you. I would like to address more the question about integrated approach around the adolescent girls, and then basically on how we link nutrition with family planning. In India, you have two systems around the adolescent girl. The Sabla system, which I spoke before about, which is dealing partly with nutrition, but it's not dealing with family planning and all the other kinds of issues what adolescent girls are addressing. Then we have the Asha worker, and she's addressing the family planning part of the adolescent girls. These two female frontline workers are working at the village level. So what we are trying to do lately, and also what is foreseen under the adolescent health strategy, is making sure that these two women are quite often, most of the time, I believe it's always women, that they are working together. So when they go to the household, that they are exchanging information. Also, they are doing teen clubs with the adolescent girls. And specifically at the village level, they speak far beyond family planning issues. They speak about nutrition, but they also speak about life skills. They speak about life options. Because sometimes we tend to forget that these are also girls in their own right. They are not, and I was very happy, who was it? Well, one of us said, sometimes we always think that girls all want to become mothers, but also girls have their own aspirations, and we have to see that it's a rights-based approach as well, that they can really work for themselves and building their own future. So therefore, nutrition is part of building your own future. Family planning is part of building your own future. So let's really make sure that the girl can stand for her own rights and she can build up for the community. And we work a lot with role models who have been able to stand on the local parliaments. For example, India has a 33 reservation for the local villages, for the local parliaments. And they see a lot of examples that women are now speaking out much more in the advantage of the services at the village level. Also why we are putting a lot of emphasis on the girl child, because at the moment, what I said, the enormous amount of adolescent pregnancies, every day in India, 9 girls are dying of pregnancy-related issue. If you say 9 a day, that means a plane crash a month of adolescent girls who are dying of preventable diseases. And it is strongly related to nutrition. If the girl is anemic, if she's undernourished, I mean, the chance that she will die during pregnancy is far higher than when she would be well nourished. So these are all very much interrelated problems with what adolescent girls are facing. So you need to bring it in an integrated approach. The problem is, however, that the Ministry of Human Development, that's the Education Ministry, they are taking care of education. Then you have the MWCD, that's Women and Child Development. They are dealing with nutrition. We don't have a nutrition embassy, a nutrition ministry. Health is by the Health Ministry. So around the young people, around the adolescent girls, you have to work with 5 ministries at the same time. And that's really a challenge, and how you can address it. So we take the adolescent in the center and we see what is available for her at a community level. And that's probably the best way to build her health assets, to build her social assets, to build her financial assets. And I was very happy that you were talking about all these issues. So for UNFPA, the Adolescent Girl Initiative is one of the most important initiatives what we are bringing worldwide to the forefront. And we are trying in many countries different approaches on how we can work on the adolescent girls. But it's not only the ministries, it's also the UN agencies who have to work far more together. So we are very happy with this partnership with WFP and UNICEF, and also UN Women. We are working together at a country level to bring all the different agencies more around the adolescent girl, so that she can develop to her full potential.
In terms of family planning and nutrition integration, linkages between the two, Justine, you sort of mentioned some of the things that MCHIP has worked on in Kenya in particular. I would make a plug for the Maternal, Infant, and Young Child Nutrition and Family Planning Integration Toolkit, which was developed through a working group that I'm a part of. I believe Justine is as well. And that's on the K for Health website. So if you're looking for field experiences, tools, things like that, there's some good resources on there. I know in our project in Senegal, in PSSC, too, we have, because the package of services is integrated, it contains interventions around family planning, primarily initial offer of pill. This is happening at the very lowest level of the system, so there are some limitations in terms of the types of things that can be offered. We are doing some piloting around long-acting methods at the community level, but that hasn't been rolled out yet. Sort of depends on what the national policy will allow TBAs and other community-level workers to distribute. But the tools that they use within the project do incorporate family planning messages, nutrition messages around maternal nutrition, as well as infant and young child nutrition. So that's all sort of packaged together, because you are seeing, mom is coming with her baby. You're not seeing them separately. It's not, I'm going to go over here for this and over there for that. It's you're seeing them once during a home visit or during a support group or for a growth monitoring visit. And so what we're trying to do is really bring those messages together in a meaningful way that works for moms. In terms of the maternal depression and nutrition issue, Child Fund has not to date done anything specific on this, but there was, back in January or February of this year, the New York Academy of Sciences published a series of papers on early stimulation and nutrition. I think it's called Reaching Every Child's Potential. So if you go online to the New York Academy of Sciences website, they have all the papers there. It's open access. And there is a paper from a study done in Pakistan looking at sort of the operational pieces around how do you bring together interventions to address maternal depression, maternal mental health, and what the nutrition implications are there. I know that IMC has done a little bit of work on this in some emergency settings. So I'm happy to, I don't remember who asked the question. I'm happy to put you in touch with my colleague at IMC, who I know is working on some tools and things, if that's of interest.
In terms of nutrition-sensitive approaches, I think I mentioned the focus of our school feeding programs. Again, we reach upwards of 20 million children. We work with national governments as they implement their school feeding programs. This is an important safety net. The Lancet actually really highlighted in this last series in 2013 the importance of focusing on areas such as agriculture, education, and social protection. And social protection really offers a huge opportunity to make dramatic changes in undernutrition, given the fact that they are incorporated into national plans. They're not that one-off nutrition program that comes in and goes out. They're systemized and they have those linkages already built in. The other areas where you could support nutrition sensitization is in public works programs. WFP really works on food for work programs, food for asset programs, where we provide food support as communities build roads, or we've done this in places ranging from South Sudan, or plant trees in previous decades in China. We need to, the key to nutrition sensitization is innovation, and also making sure that these programs have clear nutrition objectives from the front, and then those outcomes and outputs are measured throughout time. A food for work program that could be very interesting is you have women who are working, and perhaps you just put a small little hut on the side to make sure that the women who are in that program are meeting their nutrient gaps, or making sure that women who, once they learn that they're pregnant, have access to the right nutrition and food support, as well as the other necessary interventions that we've discussed here.
So before I open it back out to the audience, I wanted to make sure to give you all a chance to ask each other questions, too, if any of you had anything you wanted to pose to another. Okay, well then, again, one quick comment before I do open it back to the audience. I was curious, I know that Frederica made a comment in there about providing services to married adolescents and programming being different for those that are unmarried. So I was wondering if any of you, the others of you, had any other experiences that you can share about the difference between married and unmarried adolescents. And some of that is obviously in prep for an event we're having on Wednesday from 3 to 5 on programming for married adolescents, in case you're interested. Any comments on that?
I know it's something, when I was in Senegal recently, it was something that came up. We did a joint technical trip, myself and the technical specialist on our Life Stage 3 team who focuses on sexual and reproductive health for youth. And it was a question that we asked at every health hut that we went to visit, are you seeing adolescents who are not married because of the tendency for early marriage in a lot of the communities in Senegal? And we were asking a lot about, well, do unmarried adolescents have access to the family planning services in particular? And the answers really varied. So it is something I think that's a major challenge in a lot of settings, that, on the one hand, we're trying to delay marriage and delay first birth, but, the fact of the matter is we are working in a lot of contexts where marriage does tend to happen early. And so how do we balance the sort of SRH needs, the family planning needs, in a way that is realistic, but also that we're trying to achieve some of these bigger goals. So it was definitely something that was the volunteers and health workers we were talking to recognized that was also a challenge for them in trying to sort of grapple with that on a day-to-day basis.
I just wanted to respond to what Corinne was just discussing, and I know from one of my colleagues on MCHIP, Ray Galloway, that there are some countries that have marriage registries. So when the couple is going to get married, they have to go through some kind of counseling and register to be married. I think those are unique opportunities where women can get the counseling they need. They are adolescents, probably, many of them, or very young women. And that's an opportunity. They can be counseled on iron folic acid supplementation, for example. I guess my thought is that, yes, we can reach adolescents in schools. However, there are a lot of women who are out of school, and I think that is a challenge for us to try to reach those women who are not in school. And moreover, iron folic acid supplementation, IFA supplementation, is a policy and is supposed to be global recommendations that they're given IFA during pregnancy. However, we cannot seem to get the supplies right during pregnancy and also generate demand for that. So if we're not able to actually improve maternal anemia during pregnancy, and that is policy and is global recommendation, and we know how to do it, if we do, I'm not saying we should or shouldn't focus on adolescents. I mean, it would be ideal to improve women's nutrition before they're pregnant. However, if we do that, does that divert from what we've been trying to do in antenatal care for many years? So I just want to throw that out to the panel, and perhaps others can share experiences on what they think would work. But I think that's a major challenge in the first 1,000 days in terms of improving maternal nutrition and what has been working and what hasn't, unfortunately, for a while, even though IFA is one of the cheapest, most cost-effective interventions for improving maternal nutrition. Trying to get that right, I think, is a challenge.
So I can answer a little bit indirectly to what you're raising, Justine. And to this question about adolescents, I think about it the same way as any kind of tough-to-reach population. And I had made this point that I think from a systems and delivery standpoint, we need to be more proactive. And what I mean by that is, certainly doing things that are preventative, but I think even in terms of just the way the dynamic of delivery works, is it's still this issue where we try to mobilize people and then wait for them to come. And I think that doesn't work in a lot of settings for a lot of issues. I mean, we're talking about nutrition, and I raised the point of chronic diseases, but I think the same issue, I'm thinking a lot about chronic diseases these days, which is why I'm raising it, but I think the same thought process happens when you think about delivery, where, you know, for chronic diseases, it's difficult to mobilize people to come and seek care because you don't actually feel symptoms. You feel symptoms when something has gotten complicated. So in that same, so, you know, the way I think, the only way you can manage chronic diseases at a population level, I would argue even in high income settings where there's more health literacy, but certainly in places where chronic diseases are new and people don't have a sense of it, you have to be proactive. So you actually have to proactively screen everyone, or at least let them opt out. And I think the same thing would then apply for how are you going to reach young women, especially in communities where even if those women have an issue, they're not in a position where they can go out and reach out for care. So this way you're almost letting them say that, no, I don't need anything. Certainly that doesn't trump all the issues that are there, especially gender challenges, but that way you're at least engaging with every single household, every single person in that household, and trying to at least push forward whatever core interventions or issues that you want to promote at that level. You at least have a chance to push it forward. And I think the key way to do that from a system standpoint to me would be community health workers. And I think what's interesting to me is I think about community health workers as a part of the health system, and I think we're talking about them with the broader notion of them being working on an array of fronts, and I think that's the right idea. They can really be a place where you can commonly interface a lot of different, seemingly different programs, and allow them to actually proactively go to the household and then make sure that people are linked to whatever other upstream systems and programs they need to get plugged into. So I think community health workers can be a great link to be able to do this. And I think from the standpoint of reaching young women, you in settings where that is an issue, a lot of your community health workers will be women. So in India, certainly the community health workers are women. So that allows them a certain reach that you couldn't have otherwise. And then then this other question I think of, you know, so trying to create adolescent-friendly services is just, I think, a little bit of a challenge, and I think also going to be context-specific. I work a lot with the government in Nigeria, and one of the huge challenges we have in the northeast and northwestern parts of the country, where you have very low coverage for antenatal care, skilled birth attendants, you name it, is that it's hard to actually, you know, so women will only accept services from staff who are women. But because fewer than 30% of girls actually go to any school, like ever, literacy is like 20%, you have a really difficult time actually finding people to recruit and train to be your health worker. So it's like this huge cycle, and, you know, how do you actually try to trump that? So one of the programs that the Nigerian government has been doing is a program to recruit midwives from other parts of the country, then deploy them in high burden areas. That hasn't worked, that's worked somewhat, but it's really difficult to retain staff, and there's a lot of cultural differences still. So I think, which is, I'm posing it more as a challenge, like that breaking that cycle is very difficult. But I think that's also where I think looking at the context and the place, what are the opportunities for trying to do that vis-a-vis the local, because it's not the same cultural factors that are driving that issue in northern Nigeria as they are in, you know, Rajasthan, for example, in India. So I think it's trying to figure out what are those drivers of gender inequity, and certainly there's common patterns. But I think in terms of trying to find entry points to try to break that cycle, I think there would probably be unique issues you can tap into, or unique institutions that you can tap into in either setting, and then try to at least figure out how you can start interrupting that cyclical process.
More comments or questions from the audience? We have one up here, and one back. Moses, you can grab the one back behind you too, and then we'll come up front.
Hi, I'm Allison Roberts with the CSIS Global Health Policy Center. This is a question for all the panelists, but it's kind of based on Dr. Ranu's comments. You mentioned the health system delivery issues, but also that this is at a certain point a normative issue with communities, that in areas where women have high literacy or they're empowered, they will ensure that their children are immunized. So how do you see kind of community-based interventions working and integrating and complementing health systems integration or health systems interventions? And kind of in a scarce resource setting, how would you prioritize that?
Maybe we'll grab this next question and then we'll do it all together. Oh, you want it now? All right, he wants it now. Go ahead.
Gives me less time to think of a good answer. So I think I think the bottom line is, in some sense, you need to figure out how to do everything, right? And so that's a challenge because organizationally, and it can be a challenge in terms of resources. But I think at the end of the day, you need healthcare that can actually interface with people closer to their homes. And that sounds very intuitive, but that's actually somewhat exceptional. A lot of people cannot access healthcare close to their homes, and there's so many barriers that are erected because of that, not just geographic, but also some of these gender issues and beyond. I think care-seeking behavior is a huge challenge, to be frank. I think, again, kind of talking about the chronic disease analogy, but I think it applies where even in cities in India, for example, where you would supposedly have populations more aware of chronic diseases, their utilization of services is still far lower than what it should be to actually have those diseases managed. And I think the same analogy applies to poorer, more remote communities where there's not a notion of when you should be accessing services, which is also why I think, usually when we think about healthcare systems, we think about access and delivery a little bit separately. I think it almost has to be merged. And the way I think about that merger is you're proactively forcing people to access, and they can still opt out, but you're sort of being the one provoking it. I think so. So one is you need local level systems, and I think in a lot of settings, a combination of clinics that truly integrate community health workers is a paradigm that a lot of countries are using. But what oftentimes what happens with community health worker programs is they don't actually, on paper, they're integrated with the primary clinic. Every document will say primary care integration, but there's not a lot of coordination that truly happens, right? Where it's like the community health workers are out there doing something, the person in the clinic's doing something else. And particularly for anything that's a chronic illness, mental health we talked about, even I would argue for, supporting households where malnutrition is a problem, where you need to do ongoing follow-up, that coordination doesn't happen. Theoretically, it could happen if somebody in the back room calls the community health worker every week and says, oh, did you follow up at so-and-so's household? But that coordination doesn't happen, certainly doesn't happen at scale. The other challenge I'd say is with the community health worker programs is at large scale, it's been very challenging to get them to work well. Some of that has to do with a lot of reasons. One issue is, of course, it's tough to manage people who are not all sitting in the same place, so there's not that direct oversight, right? Secondly, a lot of the people who may become community health workers, and so I have relatives of mine who live in villages in India who are community health workers. They've never worked in a sort of job that has sort of like a 9-to-5 schedule. So the notion of actually having a work plan, I'm going to these 3 households tomorrow, these 2 households the day after, is a little bit new and different, right? And I think there's not as much structure and support for that. All this is to say, I think if you actually made that integration between the clinic and the community health workers better, and supported the community health workers to actually really have a coordinated approach that's structured, you could do a lot. And actually, that wouldn't actually be that expensive. We're talking about resources. Certainly, you have the opportunity to intervene, malnutrition when it's early. Certainly for any chronic disease, you can identify cases early and manage them aggressively. So in the long run, I think from a cost standpoint, it's better. The other thing I'd say is, I think as a separate whole focus has to be how are you going to engage the community in a very meaningful way. And I think that's somewhat context dependent, and that can happen. I wouldn't actually even put that on the health system per se. So the people who are working at the clinic are too busy seeing patients. For them to be then having meetings with the local village councils, et cetera, I think becomes really cumbersome, and it doesn't happen. Everyone says it's happening, but I feel like in a lot of places I go, it's symbolic at best. So I think trying to figure out how to actually do community engagement in a more meaningful way and make the community itself really mobilized around issues. Awareness doesn't happen overnight, but it certainly can happen. And I think how to do that is very difficult and very context specific. In India, they try to create a stipulation where there should be village health and sanitation committees. How well established those committees are is a little bit variable. So, and I think some of it is you have to find out what the unique ecosystem is in each place. So I used to work in Rwanda. So Rwanda is a place where power dynamics and administrative dynamics are very top-down, very centralized. So households are actually organized to every 10 to 20 households is sort of an administrative unit, and it's a real thing. So we could discuss something at a 25,000 person level, and the next day every single household will know it. And that functions well. In a place like India, India is the opposite, where it's a little bit of a free-for-all. There's not strong state power. Power and administrative capacity is very decentralized, which is what makes it more complicated to do anything at scale. But it also, to me, creates an opportunity where things are a little bit more dynamic. And you can actually figure out, so I would actually say in each place you'd figure out who are the players, how do they function, and then how do you get in there. And I think we can be more thoughtful about how we do that in the way we actually design a health system and the way, there's a health system that's on the ground and then there's the administration that sits at whatever level. I think that administration has to be sort of tasked with trying to figure out how to meaningfully engage the communities further down in not just like symbolic meetings, but I think something that's a little bit more engaged. and robust.
Any more comments on community-based interventions and health system approaches? I think it was a broader question for the whole panel, too, if anybody wants to add.
Well, maybe to add on a little bit, I do think, I mean, one of the problems in India is that the community health worker is a non-paid function. So the ASHA, she receives results-based funding. So she's not part of the health system. However, she has to perform all the issues for the health system. She even has to perform this health and sanitation committees at the village level. And she has to work together with the people from the grassroots level, who are the so-called PRIs. There is one state, however, in India, which I'm not going to name, but they do pay a salary. So our challenge is now to find out what is the difference between that state and all the other states. And we also have done a research in another state, where we looked at what difference does it make that an ASHA, she's called an ASHA, that she has now money in her hand. And we see very much that this is a kind of silent revolution happening at the village level, where all the ASHAs now do have money. Before they didn't come out of the house, but now they go from door to door to deliver, for example, contraceptives. That's one of them. And if they deliver a certain amount of contraceptives, then they get money. So this goes for every task she's doing, she gets money. So she's very much, and I must say this is even part of the patriarchy as well, because the men say in the health system, they say if you pay her a salary, she's not motivated anymore. So I'm always challenging them. I say, if you don't pay a doctor by patient, is he not motivated anymore that he would take care of his patients? So this is, again, the whole patriarchal system in India is really trickling through in this kind of specific issues as well, that why don't we pay an ASHA who's doing hard work? So I just wanted to add that.
The question up here?
Thank you. I'm Dave Rabinowitz. One of the key issues in this whole nutrition thing is education. It's evident. And one of the most effective ways of education like this is through the mass media, television and films. And doing special films about nutrition and all that basically turn people off. Nobody wants to watch. But getting the characters in regular films and especially soap operas to model the behavior you're trying to create, for example, having young women take IF8 pills without saying anything about it, just as part of normal life, could be very effective. Is anybody working on something like this?
Yeah, I'm very happy you are bringing this up, because we have just started funding a soap opera in India who is bringing all these different issues in one. It talks about family planning, it talks about nutrition, it talks about all the patriarchal issues and gender bias sex selection, which is a big problem in India. So it brings all these issues together, and the numbers who are viewing, it's every Saturday evening from 7 to 8, and it's going up, day by day. And so now we are also planning to discuss this series in teen groups, so that young women can sit around the television at the village level and really talking. It's also linked with social media, so people can also do all these kind of things on social media. So it's a whole campaign around, starting with a soap opera and all the different elements around it, yes. And we hope to use it more for also monitoring. That's the next step.
And that's the show that's on Doordarshan now, like
It's on Doordarshan,
yeah. So for those of you who've been coming to the series, it was September of this 2013 where we had our collaborators for Population Foundation of India come and present here, and Poonam specifically talked about PFI's work with the national cable. For this program, and there was a lot of excitement about it launching, so it's exciting to hear that. I have to find
and one
out
thing is, so we now also put it on the radio. It's not only on television, because at the rural areas, it's now also a soap opera on radio, which is also reaching more out.
And then broader than that, I mean, I know that my parents get like 20 Indian channels to, like satellite into their home each evening, and I should ask if that's on their radar, because that might be the only soap opera of theirs that I approve of. The rest are like just an insult on intelligence, I think, although I do like my Jersey reality TV, so I should just stop. There's another question up here.
Hi, my name is Megan Murphy. I'm also with FHI 360. Thank you all for really addressing some different aspects of the continuum of care in relation to nutrition. It was great to hear about different parts of the life cycle, health and non-health aspects of the continuum, and this idea of broadening the definition of the continuum beyond just traditional nutrition and health services. And I was also really happy to hear about some of the work that's been accomplished through the HIV and AIDS work that's happened to really, I think, really bring nutrition into that fold of the range of different services that people affected by HIV need. And I did want to ask, actually, our last panelist to speak a little bit to the improved, you talked a little bit about some of the work the WFP's done to fund food support and its role in increasing HIV adherence and retention in care and treatment programs. And just wondered if you could touch a little bit on which countries some of those outcomes have, you've seen those, and kind of a little bit more about those programs if you have time or have that information available.
Sure, probably some of the specifics we could maybe speak afterwards on, but the theory is that, the concept, and we've been working very closely with PEPFAR, for example, in Ethiopia, to scale up the nutrition and food support that we provide to HIV and TB affected persons, and we've found that it is being shown to be very positive in terms of adherence to treatment, and also we work in terms of mitigating, providing a safety net to mitigate against the other negative consequences of being HIV positive or TB positive. As I mentioned earlier, is if you're sick and ill, you don't have the same levels of energy to go out and work, and particularly in places that are rural where agriculture is a predominant form of income. So we provide that food support as a way, as an income transfer, basically. So that's been shown to be positive. I can't tell you right offhand right now the countries we're working in, but I do know we have select countries, 33 countries where we do work in some operations. I know Zimbabwe, Ethiopia, and I can get you more information perhaps after the talk.
I think we have a question in the back there.
Hi, my name is Julia Hotz, and I'm a reporter with IPS News Agency. So I'm coming at this at a very different angle than most of you. But so my question is actually piggybacking off of Dave's, and Frederica, I really appreciate your comments about how both social media and the new soap opera and how that's really been instrumental in education. So I'm wondering if the rest of the panelists can talk about how not only maybe digital technologies are helping with education and awareness and, specific local solutions, but also mechanical technologies, if there's been innovation in terms of public health delivery, thanks to technology as well. So.
I can take a first stab at that. So I think, I think there's a huge amount of possibilities within that sphere. So connectivity is definitely going up. It's people having cell phones, but then the capacity you have with those cell phones is greater. I anticipate smartphones will become, very common in some remote areas in the near future, in the next couple of years. So I think smartphones is allowing you a whole new basket of opportunities to engage people. So I think from that, I think there's a lot of interactions that people are having. In terms of what you can do around innovations in delivery, I think once smartphones are something that are, I think, thoughtfully integrated. So technology sometimes I think gets thrown out there, and it's sort of a little bit incoherent with everything else that's happening in the system, and it's just one more thing that's there. I think if we think about how to actually systematically integrate and deploy a lot of the technologies that are on the horizon, the increase in capacity that you'll have is, to me, massive. Because I think in the next 10 years, we'll have so many different diagnostics that we currently do at the hospital level, we can now do at a decentralized level. Even point of care, genetics testing, all those things are not dreams. These are things that are imminent in a way. The question is how to actually deploy them efficiently and be able to deploy them in a way that you can react to results appropriately. So I think that's one challenge. The other thing I'd say that's exciting about the technology is that I think a lot of medical technology, and so I'm speaking very specifically about medical and health, and sort of more traditional health stuff now, but medical technology sort of before 2000, a lot of it was were innovations that required more infrastructure and higher skills. So it's like pacemakers, things of that nature. Now a lot of it is the other direction, which is it's technology that requires less specialized skills and can be used in a more decentralized way, which to me is game changing in the sense that a lot of what used to require people to have to go to places that had more infrastructure, therefore higher costs, more centralized, meaning greater distances. Now you can start decentralizing. We just need to be thoughtful about how do we actually use that decentralized capacity in a way that's coherent with whatever treatment or whatever other care we need to structure around it. So what I mean by that is, if we're going to be screening people for high blood pressure at a household level, which we can do now with, Bluetooth-enabled cuffs that can actually go into algorithms that help you triage that case, right? I know people are developing technologies that are almost like Band-Aids that you can stick on your skin and it can check your blood pressure. Although that sounds fancy, it just makes it easier to me for my sister-in-law, cousin, who's a community health worker, to actually be able to do it, because using the cuff, sometimes she won't put it on right and she gets a bad reading. So it changes the game in that way, but I think then you need to be thoughtful about how do you now, at each layer of the system, strategically use that technology and respond to it in a way that you're actually providing good care. So it doesn't necessarily equate to care unless it's actually deployed effectively, which I think we've learned cruelly in the US, where we have phenomenal technologies, but as a system, we don't necessarily deploy it in the most efficient and effective ways.
May I answer?
Yeah, go ahead.
I have spoken already, but there are maybe two interesting parts which we also do at UNFPA. One is on the supply side of contraceptives and one on the demand side. So on the demand side, we on the mobile, the frontline worker, she has Dr. Anita on her mobile. So whatever, so these are all pre-recorded messages. So whatever question is raised by the village woman, she has a kind of 100 sets of cards and questions and so on. And quite often people at the village level don't absolutely believe in what she's saying. And she can always say, well, here is Dr. Anita. Listen to what message Dr. Anita will tell you. So there's a whole set of messages which are quite often given to the women at the village level. So that's very much on the demand side. On the supply side, we have set up in Odisha, which is a state on the east side of India, how can we better monitor the reproductive health commodity supply? Quite often when at certain villages there were no contraceptive pills available while people want that. So now the village health worker, she can just by a text message send up in the system. But even so, the system will then look what is the closest by health center who does have contraceptives available, and then they can move quickly from one center to the other. So it's a whole system surrounded around contraceptives, which is really bringing a huge decrease in the stock out of contraceptives. That's two examples.
Justine, did you have a comment?
Yeah, I just wanted to present the other side, perhaps maybe not as innovative in terms of having an M-Health approach, but in Egypt, we use this methodology called Trials for Improved Practices. So, we know that mass media can be expensive and soap operas, though they do certainly have a utility, and M-Health or e-health can also be used. But there are situations, many of which we're in, where talking to mothers at the household level, understanding what are their gaps and challenges, and from that, we were able to recommend to mothers, okay, are there a couple of practices that are new to you, feeding practices that you could try for a one week period, and then we come back and see how did you do, how did you respond to those recommendations, what challenges did you face, were you able to, replace some of the chips with, giving a piece of sweet potato, and how did the child respond? So after a 1 week period, we actually saw a dietary intake increase, and mothers were able to reduce junk foods. And they said, my child slept better, was less ill, ate better, had better appetite. So actually, household counseling can be a very powerful change instigator or motivator by talking with mothers, understanding where they're at. And perhaps those messages could definitely be automated, but understanding what the gaps are at the community, I think, is critical.
Any more thoughts on technology?
With WFP, we have done some work in India actually, and I think in Orissa as well, in terms of using retina scan technology to improve our identification and targeting of beneficiaries, because the big issue with the food distribution programs is a lot of people who need it don't get it, and a lot of people who don't need it get the food, or possibly not even alive get the food, and so we're using this technology such as retina scan. we're also, as an organization, shifting a lot to the use of cash and vouchers. And in our operations outside of, for Syrian refugees in neighboring countries, we're using predominantly vouchers. And so a lot of the shopkeepers, again, this is in the area of food, but there's potential to link it to health. Is, you have shopkeepers who have the list of people who are eligible or entitled for that food provision. And once a person comes in, they either have some sort of code that they provide to the shopkeeper, and it's very simple technology to improve targeting and effectiveness.
So in Senegal, we have a new project that is starting up in the southern part of the country, and part of the project is to use technology. So right now we're going through an assessment to look at really how do we want to use technology there for maternal and neonatal health and nutrition. So I would imagine that there will be some form of smartphone or mobile phone use. It may be on, we've discussed a few different options. It may be on the community volunteer side, giving them access to either GPS mapping of sites so that it makes it easier for them to keep track of where they're responsible for providing services to families, giving them smartphone access to apps that help provide information. So whether it's they themselves as the volunteer or the health worker have information, so if someone asks them a question or they need to track something. And then also, on the sort of use or the beneficiary side in terms of mothers and families. I would say the one caveat is, or there are many, but one caveat to think about is this issue of gender comes up again. And even though we're seeing this explosion of access to mobile phones throughout the world, women don't always have access to them. So it's great if we want to design this program that's going to give text messages to moms about how to feed their baby. But if mom doesn't have access to the phone, we've really got to work at all those underlying issues first, or it's not going to work.
Did I see a hand up at the end of this table before? No? Are there any more questions or comments that folks want to make? I know Justine posed a question to the audience as well. Does anybody want to comment on IFA at all? Well, if not, I do think I overshot when I scheduled the timing of this meeting. And although you're saying you don't have any questions, I know the moment we end, there's going to be a horde of people that are going to come up to ask individual questions. So why don't we formally end this then? I do want to thank you all for making the discussion rich and ask you to join me in thanking the speakers. And lastly, I just encourage you to follow us on our website, our blog, as well as on Facebook and Twitter. Thank you.